My name is Laura Esfeller, and we're so glad that you could join us today as we come together to support both patients and caregivers who are navigating kidney cancer. I realized after Joel's conversation last night at dinner, and Joel Stern, let's give a round of applause for Joel. Wonderful job last night, right? Joel did a wonderful job with last night's dinner, and thank you all for joining us. But I realized I misspoke. So I am a 9-year stage 4 kidney cancer survivor with FRCSC. Thank you. And I've actually been 8 years, no evidence of disease, thanks to ex-Alexis Cabo, so thank you very much, and 5 years off treatment. And so the reason why I share this is because I think what I hope that you all take from today is that, we're here because of hope, right? And whenever I was diagnosed 9 years ago, the landscape looked very different, unfortunately, at the time for kidney cancer patients, especially those of us that were stage 4. And now I look at what's happening in the field today, and I'm so inspired and hopeful about what's to come. And so I hope that you all leave today with that same hope as well. Can we do a quick poll before we get started to see how many in the room have different subtypes? I feel like there was a conversation earlier in last night. So if you have clear cell, would you mind please raising your hand? Great, thank you. If you have one of our more rare subtypes, such as papillary, would you mind raising your hand? Make sure, I hope that you're already buddies. And then do we have any chromophobes in the room? Wonderful. I think we're actually beating the statistics right now with some of these numbers. And anyone else that I didn't catch? And that was probably only one with HLRCC. So, I just want to make sure that before we get started, I also want to recognize our sponsors: Merck, Aveo Oncology, Bristol Myers Squibb. I believe Brad and Rachel, thank you very much for being here, along with ex-Lexis Nick. Thank you for all that you do. We are all alive because of the work that you do, and we really appreciate your support for this event and for all that you do for us, so thank you. Judy Nicholson's foundation and our mission is very simple: helping patients and caregivers navigate their kidney cancer journey through education, support, and connection. And I do want to just, before we, kind of get into things, just remind you of many of the things that the Judy Nicholson Kidney Cancer Foundation does for our community. If you want to continue learning and connecting after day, please visit our website, which we'll be relaunching next year to make it easier to navigate. We also ask you to please, if you're not already, follow us on Facebook, Instagram, and LinkedIn. And you can also listen to our podcast that I host. I hope that you listen. Thank you. Real Talk on Renal Cancer. Maybe it's, maybe a good bedtime listening for you if you need to go to sleep. But on Spotify and also on YouTube. And then we will also be posting today's symposium along with our other symposiums and forums that we have on our YouTube channel. So thank you for your support. And just another reminder that we also have in the room an organization called Count Me In the back. She is here primarily to help raise awareness for translocation renal cell carcinoma, which is another rare type. And so if you or anyone that you know has been diagnosed with translocation renal cell carcinoma, they are doing wonderful research by collecting samples in order to better understand this subtype of this disease. So thank you for being here as well. Before we get started, I'd also like to, if we could just have a moment of silence for our warriors who are no longer with us. I know that, they live on through the work that we do and the advocacy that we do, and so thank you for remembering their sacrifices today. I'd now like to introduce one of our board members, Dr. Patrick O'Malley. Dr. O'Malley is a urologic oncologist at the University of Florida Health. He's also a clinical assistant professor with the Department of Urology at University of Florida College of Medicine, and he's our chief medical advisor for JNF. And so Dr. O'Malley will be discussing new research in kidney cancer today. We also, we will not be doing a panel discussion at the end of today because we want to make sure, I know people have different travel schedules and things to do while you're exploring wonderful Colonial Williamsburg. So we will be having a short Q&A after each of our speakers. Jim will be, our lovely AV support will be having 2 microphones throughout the room. So if you have any questions for Dr. O'Malley or anyone of our other speakers, please feel free to raise your hand after the presentation, and we will get you a mic so that we can hear your wonderful questions. Thank you again, and thank you for supporting Judah Nicholson Foundation. And now, Dr. O'Malley.
Super, thanks very much. So I get the privilege, I guess, of starting off first, warming you up. So I'm going to talk a little bit about new research in kidney cancer. Obviously, based on my talk last night, I think research is critically important in kidney cancer. And it's a really exciting time for research in kidney cancer currently because there's a lot of things going on in a lot of different spaces. And so we're going to touch on not all of them because that would take probably several hours, but some of the ones that I think aren't being touched on by some of the other talks. So we'll go through some new and exciting things in kidney cancer. Kidney cancer, as we all know, is a pretty common malignancy. I think this group's a little bit enriched probably with people with more advanced disease, but the vast majority of patients are actually diagnosed with localized disease. But obviously patients who have metastatic tend to be some of the stalwarts of patient advocacy because there's an ongoing process. Most kidney cancer is, renal cell carcinoma, and most of that is clear cell, but I think we'll touch on some of the things that are coming out in non-clear cell as well. Last night I talked about, what we want for our patients, what our patients want, which is, 2 things, I think: to live longer, but I'd say perhaps more importantly, to also live better. And the question is, how do we get them there, and what are the questions to ask to get them there? What are those unmet needs? And I think, the answer to those questions and how to figure that out, it really is research. And that's the goal of research is, what are the questions and then how do we answer those? So currently, in kidney cancer, there's a couple sort of, I wouldn't say hot areas because, that makes it seem like it's a passing sort of fad. These are areas where there's a lot of developments and advances, and that's been borne out by a lot of long-term hard work on both patient side and physicians and clinicians side and nursing side. And so these are areas now that we're just starting to see the fruits of labors that have sort of been done over the last decade or so. So these sort of areas, I'm going to focus primarily on, the biomarker space and perioperative therapies. Dr. Zemp's going to talk about imaging. Dr. Zhao's going to talk about non-clear cell. Surgery will leave to another day, although obviously as a surgeon, it's something I have a great interest in. But I'm going to focus mainly on the biomarker and the perioperative therapy spaces that we're seeing a lot of changes in. So first of all, what's a biomarker? We use biomarkers in medicine a lot, some that we wouldn't even think of being biomarkers are the ones that we use the most commonly, right? So, blood pressure and heart rate are biomarkers, blood glucose or hemoglobin A1C, biomarkers for people with diabetes. In the oncology space, biomarkers are a slightly different form, and most of the biomarkers we see in the oncology space are, more small molecules like DNA or RNA, certain types of proteins, metabolites, and things like that. And so these are basically anything that you can measure that's an indicator of some biological state. And you say, okay, so we can measure these things, why would we want to measure them, and what are the questions that, maybe being able to measure this can answer for us? And so I think these are important questions if you think about your journey and things that you would have liked to know or people don't have great answers for. I think these are the questions that we hope biomarkers can help direct or guide us. So, some patients have been on immunotherapy combinations as their first line, like Ipi-Nivo. Some patients are on IO and TKI combinations, like Pembro-Axitinib. It's like, is one set of combinations going to be better for one patient than another. We don't know that, but the hope is that biomarkers may help us delineate which of those first-line therapy options may be best for you as an individual. Many patients have surgery for, particularly stage 3 disease. There is not an insignificant recurrence risk, and so the question is, we now have evidence that says if you get certain types of therapy afterwards, we can decrease the chance of it coming back and improve your overall survival. But there's a large number of patients who probably don't need any of those treatments. So can we figure out who amongst those patients that all look very similar based on the current metrics we have, is there a biomarker that tells us, oh, this person actually is really going to benefit from this, whereas this person is not? And the idea is that you can ramp up or intensify treatment for those who really need it, but at the same time de-intensify treatment for those who may not benefit from it. And that's, if you're on a therapy, well, what's the chance this is going to work? It'd be nice to have a more finite answer that maybe is tailored to you specifically as an individual. What are the chances of getting treatment toxicity, right? A big part of survivorship, I think, for particularly stage 4 patients is you are on therapy oftentimes for not weeks, months, but years. And there are toxicities that are acute and there are toxicities that are chronic, right? Knowing what your risk of developing those are, or maybe how to avoid them, would be beneficial. And finally, the one that is probably most important to most people is, do I have cancer? Am I free of cancer, right? We celebrate a lot of times when people are NED. Most of that is based on imaging. But are there more sensitive techniques or biomarkers that we can use to tell us more specifically, more accurately, that yes, you truly don't have any evidence of disease? So, biomarkers aren't new in medicine. We are seeing a sort of surge of them across medicine as a whole. An example of this, is in breast cancer here. This is patients with a type of mutation, and receptor mutation in their breast cancer. And actually it makes a big difference for these patients whether they get the chemo before or after surgery, right? So you wouldn't think that, you think it's still, you get chemo, you get surgery, you get chemo. It wouldn't be a big difference, but in some circumstances, because of how these drugs work, it can make a big difference. So this is an example of a biomarker that says, hey, you should actually get your chemo after surgery. In a sort of more urological space, I do a lot of bladder as well as kidney cancer. There was a bladder cancer trial where they looked at giving patients atezolizumab, which is an IO therapy, versus observation. In patients, after they had their bladder removed, they still had aggressive disease. And when they did this trial, it was negative, right? There was no benefit to giving these patients this adjuvant immunotherapy afterwards. What's interesting is after the fact, they've gone back and looked at this, and they've looked at a biomarker called circulating tumor DNA, which I'm going to talk more about. And they said, well, what happens if you had a positive circulating tumor DNA, i.e. you had a higher risk of having your cancer come back to begin with? So interestingly enough, when you look at those patients, they actually had a pretty significant benefit from the immunotherapy. So again, the biomarkers, these patients wouldn't have gotten this therapy. If we have accurate biomarkers that tell us these are the people who are really at risk, these are really people who benefit, we can give them more treatment, and the people who were ctDNA negative can avoid the toxicities of treatment because there isn't a benefit for them. So biomarkers, I think we're going to see, are increasingly more important for tailoring treatment for patients and figuring out how to maximize your benefit while limiting your toxicities. So a little bit about circulating tumor DNA. I think you're probably hearing more and more about this to some degree in the kidney cancer world. Historically, it's not been a big topic, and there's some reasons for that. This is basically what they call a bespoke assay, which is a great terminology. But if anyone's ever had a bespoke soup made, they know it's like a one of a kind. So these are individualized assays. They're based on, they take a sample of your tumor, and then they take a normal sort of blood sample, look at your normal DNA, and they say, what's different in the DNA of your tumor in you as an individual versus your normal DNA? And that's how they can sort of say, well, there's DNA floating around your bloodstream. Is it from the tumor? And is the tumor maybe hiding somewhere or not? And so it's a very sensitive test. It's individualized. The first example of the use of this has actually been around for a while now, was in non-small cell lung cancer back in 2016. That's when this sort of started coming about. And it's now been used in more and more cancers. There are limitations, right? So this is a very sensitive test, but it doesn't tell you where the tumor is or where it's come back. And it also varies. So the reason you haven't heard a lot about it in kidney cancer is that there are some issues with the biology of kidney cancer versus, say, bladder cancer or lung cancer that make it you've got to tweak things a little bit to make it usable. And so that's why you probably haven't heard about it a lot, is because the location or the tumor type in this case is a bit of a limitation in kidney cancer. So because this is a very sort of microscopic assay, it is extremely sensitive. So as most of you know, I heard a number of people talking about, when that day they go in and get their scan, right? Like it's all about what's my scan result going to be. And scans are sensitive, but they have limitations on how much they can see or how little they can see. The circulating tumor DNA, on the other hand, is much more sensitive. So before any imaging sort of shows up anything, we're finding in bladder cancer patients, their circulating tumor DNA will actually become positive. And it's like not just like a couple of weeks before, and it's usually months in advance. And this may pose several benefits, right? So if you've had treatment and your circulating tumor DNA is negative, and all of a sudden becomes positive, you may be able to start on treatment to attack that when it's at its smallest amount, right? Months before you would start on it based on conventional imaging. So it's a far more sensitive test. It also may be something that we can use that biologically represents what's happening with your tumor. So some of you have had, systemic therapy, and then your scans are stable, or there's some changes, but they don't know, is that just dead tumor? Or is it, is there active tumor there? We don't know. And the only way to find out is either go in and take it out or do a biopsy. So some of these tests may give us some insight without having to do those invasive procedures. If your imaging looks stable, but your circulating tumor DNA has come down, you'd say, look, biologically, this thing may be there, but it's not active, and your cancer is being well controlled. So there's a lot of potential for these biomarkers. But as I said, there's limitations in kidney cancer with circulating tumor DNA, right? And a lot of that comes down to the biology of kidney cancer. There is a lot of heterogeneity within tumors, right? So if you biopsy a small renal mass, that's like 2 centimeters, you could probably do one core, and that's probably representative of that tumor. But you go to 5, 6, 7 centimeter masses and you biopsy that, you'd actually have to do somewhere between 5 to 6 cores to actually have an accurate representation of what's really going on in that tumor. So there is this spatial heterogeneity that exists in these tumors. There's also temporal, right? These tumors change over time. And some of you see that where, you have progression of disease, you start on a treatment, and the treatment works on some tumors, but not on all of them, right? And so there's this sort of, some got better, some are the same, some may be worse. So there is this sort of temporal variation between sites of disease, and that makes it difficult to sort of target with these assays. Kidney cancer as a whole has a low frequency of sort of mutations compared to other tumors. That means that the targets for these assays, these little sort of markers for each individual person, there's a lower amount of them. And because there's a lower amount of them, there's less you can target. It makes it a little less sensitive. And so you have to be a little more precise in some ways with it. And then surprisingly, kidney cancer is a very sort of immunogenic, but also a very vascular type of tumor, right? Many of these drugs like TKIs and VEGF work on the sort of the angiogenesis aspect of these. So you would think tumors like this would actually probably shed a lot of DNA into the bloodstream. Interestingly, kidney cancer sheds very little. So it's considered a low shedding type of tumor, and so you get very small amounts of circulating tumor DNA released from kidney tumors. So that means that your ability to detect them is reduced because they are much lower. And so you have to be able to dial up the sort of the sound or the volume on your signals to pick them up. But you've got to be careful because when you do that, you can also pick up more static and more noise. So to date, this really hasn't become a mainstream thing in kidney cancer, but it is coming. This is a publication from last year, a group in Temple and Fox Chase. And by tweaking the circulating tumor DNA assay a certain way, they're actually able to show that it's actually predictive both before you have surgery and after you have surgery about how you can do long term. So while this isn't prime time yet, it is coming, and I think within the next 2 or 3 years we'll see this is going to start being used on a more regular clinical basis. It is starting to be built into prospective trials that are coming down the pipeline as well. So if you're in a trial in the next 2 or 3 years, you're probably going to see this, and if you're not in a trial, 3 to 4 years, you're probably going to see this as well. So in summary, it's certainly got some promise. In other tumors that we've used it, it's worked very well, but it's not validated yet in kidney cancer, and it lacks a bit of standardization because, as I said, you have to tweak it a bit to get the right the right signal. But it is something that we're going to see more and more of. So the other big biomarker in kidney cancer that's coming out is this one called KIM-1. This is kidney injury molecule 1. Very original name. This is a type of protein that exists on the surface of the cell, and then it goes through a process where it gets cleaved off, and then it circulates in the bloodstream. There's been some really nice research that looks at like the molecular underpinnings of how kidney cancer develops. And what we found is that when you have a tumor that shows up in these small masses in your kidney, that kidney actually tumor really started probably 10, 20 years ago. Not just, the actual appeared, but the actual molecular changes that would lead to that actually started way, way, way earlier than you think it did. And interestingly enough, this marker, if you go back and look at people who were newly diagnosed with kidney cancer, if you actually have blood samples from previous years on these patients, you can actually pick up these KIM-1 markers going up or being elevated 5 years before you're actually diagnosed. So 5-year lead time on having a diagnosis that you can see on a scan is pretty impressive. We also know that if at the time of diagnosis you have higher levels, you also have a higher risk for having mets down the road. We know in patients who've had, say, surgery for stage 3, if you have higher levels beforehand, your risk of having recurrence afterwards is also higher. And we know in the metastatic setting, if you're on treatment, you start on treatment and your KIM-1 levels actually go up, it's a bad sign, right? So this is a biomarker that seems like it's going to be useful in a number of settings. So to sort of evaluate this retrospectively, there's a couple of studies that have been done in the past, the Motion 010 and ECOG 2805. These were adjuvant therapy trials that were actually negative, right? So Motion was nivolumab versus observation. It was a negative trial, but what they found is in both these trials, if you go back and stratify patients based on if their KIM-1 was positive or high, those patients clearly have worse outcomes. The question is going to remain is, does that mean those patients are also going to benefit from therapy? We don't know that yet, but you can see in those charts on the right, based on how high your KIM level was, the higher it was with each quartile, you can see the worse the survival was in those patients. So this is a very promising biomarker, and I think we're going to see more and more of this. I think its real role is probably going to be in helping us pick out who's going to get adjuvant therapy after surgery in those stage 3 patients. But there are some patients who don't fit the qualifications for getting immunotherapy after surgery that, sure enough, over time, go on and develop mets. I think this is actually going to help us select those patients that you would presume are low risk, but actually carrying occult high risk features that will make them develop mets down the road. Those are patients who wouldn't have the opportunity to get the therapy early. If their KIM-1 levels are elevated, then we may be able to give them therapy sooner than we normally would and maybe prevent them progressing to that metastatic state. As I said, because it predicts development of the tumor before you can actually see it on any scan, there may be a role for screening. And then the other role is potentially, response to therapy, right? So radiation, for instance, for renal masses, for the actual kidney itself, that is coming in the next 5 years. One of the problems with that is that when you get radiation of your kidney, it works very well, actually, in the short term. We don't know long term yet, but it does work very well. But one of the problems is that when you get your scan 6 months later, it looks exactly the same, which freaks patients out, freaks physicians out, definitely freaks the radiologists out. The reality is those tumors actually respond really well, but it just doesn't look like it. But biomarkers like this KIM-1 may be able to help us say, hey, look, your KIM-1 levels dropped way off, you're good, right? We're just going to keep an eye on it, don't worry about it. But those are things that are being worked on. There is a trial that's in development at a national level where this is a biomarker that's being involved in the radiation trial. So hopefully we'll see these results down the line. So switching gears, I can talk a little bit about perioperative therapy. Patients with locally advanced disease have a not insignificant risk of recurrence after surgery. Can we decrease that risk by giving them systemic therapy before, after, or both around the time of a nephrectomy? Can we make that road ahead less bumpy? Historically, this has been a very frustrating space, certainly for physicians and probably more so for patients. The risk of recurrence, just over half of patients are disease-free at 4 years, which means almost half of patients have had a recurrence. Now that's a broad, heterogeneous group of patients. But that's still a number that we'd like to see a lot higher. We'd like to see it be like 85, 90, 95, 100, right? We have seen significant improvements in metastatic kidney cancer patients, right? You know, in the trial that sort of sunitinib got approval for, this is going back now a decade or so, but sunitinib improved the median overall survival in that trial was 21 months. That was an improvement from about 7 months in the interferon IL-2 era. Ipi-Nivo in the first study that sort of announced its arrival in kidney cancer in the metastatic setting versus sunitinib, there was a 75-month disease-free survival on average in that. So we see that these treatments in metastatic therapies have gotten better and better. And the thing is, can we use that earlier to reduce the risk of recurrence? Because many patients, they go through the surgery. If you told them, hey, if you do this, you can decrease the risk, most people would be like, sign me up, right? Knowing that there are toxicities, but knowing that, as I said, you want to live longer and you want to live better. So we've tried this for a long time. And we tried it with the targeted therapy era, with tyrosine kinase inhibitors and VEGF. There was actually 6 large trials done, looking at these drugs like sunitinib, pazopanib, and here's the 6 trials. Only one of them was actually positive. The rest all showed no benefit to this adjuvant therapy with TKIs or VEGF. And the one that did show a benefit only showed an improvement in disease-free survival. But when you follow those patients over time, there was no difference in overall survival. So it didn't help you live longer. It meant that your disease came back later, although you could argue it wasn't clinically significant in a sense, but you also got the toxicities with the treatment. So not ideal. Moving forward, the age of immunotherapy, you can see that, the landmark events in this pathway are coming quicker and quicker, which should give us hope that more and more therapies are on the way. But, immunotherapy comes out 2015, 2016, first with Ipi-Nivo and then subsequently with a number of other combinations. So, the question is, okay, new drug, new results, can we do better with this one? So, yes, kind of. So there's actually 5 trials done in this space, okay, with immunotherapy. And only one of these is actually positive. Now, the Keynote 564 showed not only disease-free survival, but an overall survival benefit. And it was pretty clear that there was a benefit for that. These are all those trials. The Emotion 010 I mentioned, Checkmate, Prosper. Rampart has not reported. We had Prosper open at University of Florida. This is, you basically got nivolumab before surgery and after surgery. And I would say, we were very optimistic. We thought, yeah, this is going to really work and it's going to be great and patients are going to do better. And it was negative. I will say there are some key differences between these trials that probably account for why some of them may have been negative and only the one was positive. But if you look at the one that was positive, the randomized trial, it's the pembrolizumab versus placebo. There's almost 1,000 patients in this, and you basically were allowed to get the drug every 3 weeks for up to a year, essentially. Obviously, there are some adverse events, and they had the sort of pre-specified disease risk category. And so you had low risk, high risk, and you even allowed patients with metastatic disease as long as they had one site and it got resected within a year of when they had their kidney taken out. And the results from this, you can see those curves are pretty well separated. The worse your disease was, it seemed like the benefit was even greater. So those patients who had maybe one lung met or a spot in their adrenal, those patients seem to really benefit the most. There's a 70% reduction in the risk of developing mets down the road. So this study wasn't like borderline positive. It was pretty clear-cut positive, which is good. It's approved now, and it is being used. That said, obviously it has some serious side effects. About 20% of patients, so 1/5 of patients had serious side effects. I will say, we always see these numbers. If you look at the placebo arm, where basically they got a sugar pill, that serious event rate is still 11%, right? So, patients with advanced kidney cancer have side effects. Not surprising in many ways. But, that is a cost to patients because, as I said, you want to live longer, but you want to live well. And so if your risk of recurrence after you've had surgery is very low, you may say, I'm going to more likely get a side effect than a benefit from this. So some people have looked at other ways you can actually stratify patients based on the factors we have now. that maybe say, hey, you're less likely to benefit, you're more likely to benefit. But the real answer to that question is really going to come with biomarkers, right? Like KIM1, circulating tumor DNA. That's how we're going to pick out the people who are going to benefit the most. So what's coming next? Just 2 trials here I'll mention. This NeoVax trial, it's avelumab plus axitinib. This is sort of neoadjuvant, so they get therapy and then they get their treatment. And the primary endpoint is actually to see that the tumor before surgery actually shrinks down. That's starting to report out some results. There is a vaccine trial coming. So these are called personalized cancer vaccines, or PCVs. This is a new sort of type of therapy, but we're going to see more and more of these. Obviously, cancer is not a virus, but vaccines elicit immune response. That's how they work, right? And so, just like immunotherapy works for kidney cancer, these are likely to help your immune system attack the cancer. Okay, this is a very early stage results of 9 patients. 2 of these patients in this study actually had stage 4 disease. Currently, all patients at about 40 months of follow-up have no evidence of disease. I will say that those stage 4 patients were the ones who had limited disease, and they actually had those resected prior to the vaccination. But nonetheless, I think the results are still promising. This is basically how they do this. They basically take a sample of your tumor and create the vaccine in the lab and then give it back to you. But this is obviously a new and exciting thing. There is also a trial being done nationally called STRIKE, which is after surgery, if you're a candidate that would normally have gotten immunotherapy, you get randomized to either get immunotherapy or immunotherapy with pembro plus tivozanib. And so we have that open currently at our institution, and we'll see if that improves. Obviously, with that, there's more toxicity because you are adding in that other drug. So we'll see. It'll be interesting to see if that actually ends up being a positive trial or not, and how well tolerated it will be. I will say patients have a hard time accepting the potential increased risk of toxicity in that space right now. So we shall see what happens down the road. So ultimately, I think, the unmet needs that we have, research is the key to answering these. These are the area where there's a lot of advancements, a lot of changes coming down the pipeline, a lot of work being done. And I think it's, as a physician, it's an exciting time to be a kidney cancer specialist and surgeon. And I think it's a great time to be a patient, right? And 5 years from now, it's going to be an even better time. 10 years from now, it's going to be an even better time because we're going to get better and better at treating these. And I think, you'll hear the non-clear cell from, there's quite a number of patients in here. That is also something that I think has been not ignored, but maybe not as prioritized as it could have been. I think that's starting to change a lot more. A lot of trials are including more non-clear cell to try and get more data on those patients. And so there will be more options for you as well in the future. So with that, I'll say thank you. I enjoyed being here. Had a nice little run out this morning in Williamsburg. It was very nice. So thanks very much. So I think, do we still have time for questions? Yeah, we'll go there and then there. Yeah.
Just two questions. I know you didn't really touch on Checkmate 214.
Yeah.
This is just a question I've always had. Being a former CFO and a CPA, I look at that chart on Checkmate 214, and just a question I have. I mean, I look at the flattening tail. Why won't oncologists come out and pretty much say there's a good chance that we've cured people with stage 4? Because that tail's got so flat after 7, 8 years. To me, what's holding them back from? Because I mean, that gives this group true hope. We all want to hear we can be cured, and it looks to me Checkmate 214 has cured 25% of the people.
Yeah, I think there's a couple different reasons for that. I think historically is one of the big reasons, right? It's like, stage 4 is not a curable disease, right? Historically. And I tell my patients, like, the party line is it's not curable, it's a terminal disease, right? The reality is with the newer drugs, we do see patients who have these exceptional responses. And I say, I don't know if you're cured. Because I don't, right? We don't know, if you follow those patients another 5 years out, are they going to be? But I think in the future we're going to know if they are, right? So I have one individual, he's had 2 surgeries and he was on immunotherapy. He only got 3 months of immunotherapy, but he had like an incredible response. He had to stop it because of autoimmune pancreatitis. But he's 5 years NED with nothing, not on any drugs. And I'm like, look, if you're here 25 years from now, the proof's in the pudding, you were cured. But can I tell you that yet? No, because we just don't have the experience, right? The drugs haven't been around long enough for us to tell people that. We don't want to sort of give people false hope, but at the same time, you don't want to deny them hope either, right? So I think that's something we struggle with as well, right? I mean, as a medical oncologist, what could be better than telling your patient, look, your cancer's cured, right? So medical oncologists want to do that, but they also don't want to be irresponsible about that, right? And tell people that, and then the person comes back a year later with meds, and they're like, well, you told me I was cured, right? And so it seems like a negative attitude, but I think they're just being cautious about it until we have more data to say, look, if you're NED at 6 years after this therapy, the data would say that 98% of people in that situation are going to continue to be that. Right. So until we have that data to support those statements, I don't think you'll see the field shift to say that.
And one follow-up question. We all know Yervoy of Diva. I mean, if you ask me, that's your best shot. What's the next research drug? We know TKIs, they keep you going. We know Opdivo and Yervoy has the potential for, let's call it long-term durable remission.
Yeah.
What's the next drug that you see that would have that same potential years from now that you think's in the pipeline? Because that's really, I think, what we all yearn for.
Yeah.
Another drug that if we fail on Yervoy Opdivo, we've got the chance for really long-term durable remission.
Yeah, unfortunately, I think there's a few things that are coming down Panel 11, right? So there's what's called antibody drug conjugates. So we actually have one, and it's still in animal level development, but there are ones that are beyond that are in clinical trials. These personalized cancer vaccines, right? And that personalized cancer vaccine, when they do that, they actually inject it back into the tumor as well as the immunotherapy into the site, right? And the idea is that you get this really robust local response that then goes on and propagates. So I think you're going to see a mix of these novel therapies like cancer vaccines, ADCs, and there are some other, TKI-like drugs, but have different profiles that may get better responses, right? So Exelixis has some trials like Stellar and stuff that have some novel agents that are in that process. So I think you'll see not just one, but several drugs. I think most of them are working on the immune microenvironment because that has been so successful. Like ours works on that, right? Like, in our mouse models we've done in bladder and kidney cancer, you give them an immunotherapy drug and these tumors shrink down. You give them our drug, the tumors shrink down, but you give them both together and the tumors disappear, right? And so it's like, it's going to be this combination. And so, in that space, I talked a lot about, trying to de-intensify therapy. I think what we're likely to see first is intensification of therapy. People are going to be on more drugs, but the benefit may be that they get better responses. And so while they're on more drugs up front, they may be able to come off those and have durable, better responses long term. So you'll kind of get hit with the hammer up front, and then the back end will be easier because you'll be off drugs and have more durable long-term responses.
Thank you so much.
Yeah.
I just wanted to see if you could speak to, the federal cuts to the KCRP and what that, I don't really know what that means, in terms of all of the research that you're doing.
Yeah.
Does that mean everything slows down, or if you could just kind of speak to that so we could understand?
Yeah,
a little bit more.
without getting, political about things, as a Canadian, you can probably imagine where my politics probably lie. But I think, as someone who's, not from here, I think the U.S. has always been, clearly the world leader in medical innovation and research, right? I mean, it drives innovation, right? And it does that through funding and bringing in people from around the world and also within the United States and creating programs to create these infrastructures that create these incredible labs and incredible research. But you need funding to do that, right? And these cuts in funding, in the DOD, right? The kidney cancer funding went from 50 million to zero, essentially overnight. I mean, that will be felt, right? And already you're seeing people leaving the country to go other places because they're it's not what it was, and the funding's not going to be there, right? And so they have to go elsewhere to do the things they want to do. So I think it's going to be a real loss for the country, but I think, for kidney cancer patients, I mean, it's scary, right, to see that big of a drop-off, right? I mean, you kind of think, if you look at that first slide I have, right, at the very beginning, and second slide I had at the very beginning, you look at the rates of kidney cancer, right, they're not going down, right? They're only going up. We don't know why that is in many ways. It's not just, people are like, oh, it's because everyone gets imaging. Yes, but even when you account for that, the rates are going up. And so it's only going to be more and more Americans who are going to suffer from kidney cancer. And the longer we go on with people developing kidney cancer and staying alive, we're going to have more and more Americans who are still alive from kidney cancer. So to then get the funding for all those people, you're kind of writing off their future in a way. It's heartbreaking, and I think it's unfortunate. I think there's going to be a much heavier role for philanthropy than ever before, which is just, you're paying Tom to pay Peter, right? Like, I mean, it's like tariffs, right? It's like, oh, we're not taxing you, but you're paying through it with tariffs when you go to your grocery store or whatever, right? It's just a different way of paying it that maybe you don't get mad about. But, you're still going to support that funding. You're just going to do it through different avenues, hopefully. But until we have formalized avenues for directing people to fund that, the federal government was the best way to fund that through taxpayer money, and that's gone now, right, with that. So it's unfortunate. I mean, we'll see, these things are not always permanent, so hopefully that will be corrected in years to come. I think because there was such a sharp decline, there was a sort of vociferous response to that, so maybe next year it will be adjusted. I will tell you, I reviewed grants for DoD last year for, Young Investigator Awards. And there's some pretty exceptionally bright people out there with some great ideas. And it's like, we reviewed 20 grants, and I would say 14 to 15 of those were like, these are great ideas and fundable. And, only some of those are going to get funded, right? But now none of them get funded. It's tough. All right.
Good morning. I had a question to follow up on the question that Dan asked about checkpoint and some of these treatments that show such promise. Are there clinical trials currently or clinical practice data on using these treatments as fourth, fifth line, sixth line treatment?
Yes. So this is, as we go along and get more experience, these are questions we're trying to start to answer. Right? Like, how long should you be on therapy for, right? If you fail first line, what should your second line be, right? So there was the Tenevo 2 study, right? And it basically said that if you had immunotherapy up front, and then you got randomized to either tivozanib on its own or tivozanib plus an IO, you actually did worse if you were in the IO tivozanib arm. Right, and so it said, re-challenging with an IO if you failed an IO probably isn't going to work. It may actually be detrimental. So, these are things that, that's one trial. I think we need a little more data before we sort of say that we shouldn't do this or we should do this. But that's sort of the next sort of step, is trying to figure those things out, right? Like Pedigree is a trial where everyone gets ipi-nivo up front. If you have a complete response, you stay on the nivolumab. If you have a progression, you switch to cabo, and then the vast majority of people have a partial response, right? So after a set time on ipi-nivo, they get randomized to continue on nivo versus cabo, right, for up to a year. So, we'll see, do we sequence things? Do we keep you on the same sort of pathway until, you have a progression? These are all questions we don't know, and the trials are going to be the best way to answer that. And it's hard because there's multiple agents, and they all have slight nuances, right? We saw with those adjuvant trials, there was 5 trials done and only 1 was positive, right? One of the ones that failed was the tislelizumab. It's an immunotherapy just like, Pembro is, so why did it fail? Well, it works on the CTLA-4 rather than the PD-1, so maybe because of its mechanism of action, even though they're kind of similar drugs, one works and the other doesn't. So there's a lot of questions we don't have the answers for. We have hypotheses for, but we have to sort of verify those with trials and stuff. I'll leave it there so that we don't run behind, but I'm happy to talk to anyone in between sessions and over the breaks and stuff if you have any other questions.
Thank you so much, Dr. O'Malley. And before I announce our wonderful next speaker, I did want to just thank you for the question on the funding from the KCRP. Just wanted to let you all know that the Judy Nicholson Foundation does partner with Kidney Can, another wonderful organization in the kidney cancer community that focuses on grassroots advocacy. And so Kidney Can, in partnership with Judy Nicholson Foundation and some other organizations, will be doing some advocacy days. They're virtual, and I encourage each and every one of you to please sign up for those. It's not scary at all, I promise. Kidney Can does a wonderful job of preparing everyone as to how to talk with your congressional representatives. But the KCRP focuses on high risk, high reward. That's kind of their niche. So not all of these clinical trials, to Dr. O'Malley's point, are slowing down, but actually the personalized cancer vaccine trial is one that was funded by the KCRP. So those treatments of the future, right, the next 10 plus years typically come from that program. So again, we would love to see more participation from the Judy Nicholson Foundation in those advocacy days coming up in September. But now I'd like to introduce one of my fellow board members, and the amazing Mark Manning. He is a stage 4 kidney cancer survivor, and he will be sharing his story today with you all. Mark, welcome up.
So I was the lucky lotto winner to tell my story. And it's probably a little bumpy, you know. I'm going to try to be honest and candid where I had some ups and where I had some downs. And I guess I was thinking of something this morning, and I guess and I wrote it down, and I said, if I knew then what I know now, because in 2015, I didn't know anything. I did not know anything. I mean, this is called the accidental cancer, and it is so true. Because if we were to do a poll of all of us who are patients, how many knew something was going to go on? How many ever had any idea that you had kidney cancer? None of us did, you know. It's the accidental cancer. And in 2015, you know, it was a place I never expected to be. Kidney cancer. I felt I was pretty healthy. Life was going on. I was working hard. I had a job where I traveled all around the United States. I can't have cancer. I mean, where did this come from? So, you know, it was a pretty uncertain roadmap ahead. So I guess I'll share with you a little bit about some of the ups and downs. So, like any good sales manager through all the years, I always had themes. And these were the two that kind of were the ones that stuck and became a part of what I was as a kidney cancer patient. There's a professional golfer by the name of Kevin Kistner. Solid guy out there. You know, he's not Tiger Woods, but he's an everyday guy out there on the PGA Tour trying to make a living, you know. And his signature quote, whenever he's being interviewed by the media, was, "This ain't no hobby, fellas." And that became what I thought about kidney cancer. It's not a hobby. I mean, this is our lives now, you know. And you have to compartmentalize things and get things out of the way, because there's a thing called kidney cancer that's going to be at the front of everything that you do. So I like Kevin. It's kind of a signature quote. It kind of expressed his competitive drive, and I think it expressed my own personal competitive drive. And it's a full-time commitment, you know, and I think as we've all found, every day we wake up, we have kidney cancer, and we have to deal with it in all the different ways that it's, you know, part of our life. The other one is there's a movie called The Big Lebowski, and it's the dude, and his signature phrase is, "The dude abides." And boy, does that tell the story right there. You gotta abide, you know. you need a theme like that to drive you, to pick you up every morning and to say, you know, I can get through this. I can get through this. You know, it's not over. And as Dr. O'Malley told us, gosh, there's a lot of things that are doing. And there's a lot of things being held back now because of funding and things. And we have to keep charging, you know. And we have to be able to abide by with ourselves and with our community. So anyway, the dude kind of became my little spirit guide, let's call it. And so then I wear a dude shirt to every doctor appointment, every scan, any medical procedure I go through, the dude shows up. And so he's there with me. I think my wife's sick of washing dude shirts because I've got a kind of a good collection. But, you know, those two things just became a little bit of inspiration for me, you know. And I think when you have a disease and you have things that are happening to you, you need some things to inspire you. And those were the two that I chose. And now we'll get into the nitty-gritty. So my journey started, I was going to see a urologist about a minor urological situation. Nothing dramatic, one of those things, we go to doctors, things come up, you deal with it. But I went in and I went in for a very minor procedure, and they halted the procedure and they sent me home. And they said, well, something else is going on. I said, all right. So they said, let's get a scan. And they did the scan. And everybody, all of us have had scans, and they found shadows. And shadows on scans are not good, especially when they're on your kidney. That shadow turned into a 10-centimeter tumor. And so I'm seeing this urologist, a very, very nice doctor, very professional doctor. This was a local urologist. I live in the western suburbs of Philadelphia, so I went in to see the local urologist when I was having this issue. And one thing led to the next, sat me down, told me, you have cancer, and we have to take your kidney out. And you can imagine the wave of emotions and the wave of things that are hitting you when you're told that. And I use the expression when I was in business with customers, and we'd say we were drinking out of the fire hose. And at that point in time, I was drinking out of the fire hose. There was so much stuff coming at me. And I was overwhelmed, you know, and my wife was by my side, and we're sitting there going, okay, we got to figure this out. We got to figure this out. And so anyway, the doctor says, well, I'm going to schedule surgery, and we're going to take your kidney out. I said, oh, okay. I said, now you're going to take it out? And he goes, yeah, I'm a certified surgeon, urological surgeon. I'm going to take your kidney out. I said, is there an oncologist that's part of this somewhere? And he said, oh yeah, well, I'll have an oncology doctor there on a consultative basis. So I'm naive to this whole world of kidney cancer and everything, and I'm going, oh, okay, great, you know. And then we go home and started thinking about it, and we were going, you know, a consultative oncologist doesn't sound like I have expertise in the room, you know. And it was just a very, it was a tough time because we were trying to figure out what to do, you know. And there's no magic formulas. You got to figure out your situation, and you got to figure out how you're going to do it. And so that's where came up with this little thing that I call Team Manning. And I'll get into it a little bit more in a second. But the first person of Team Manning that came into play was a friend of mine who, she was a senior executive for a Philadelphia hospital. She was a lawyer. She was a nurse. She's probably the smartest person I've ever known. And my wife and I called her up and we said, you know, this is what's going on. Talk to us, you know? And she was incredible. She was incredible. And she walked us through all these things. She looked into the situation, looked at all my, you know, I got her all the information from the doctor, walked through it, you know? And she told me a very direct thing. And it's not a, I'm not here to disparage the reputation of any of these doctors, but what she said to me, I think saved my life, because she said, Mark, you have to get into the city of Philadelphia. There is so much medical knowledge in this city, people with expertise, with years and years of looking at what you're dealing with, you know, and God, the intentions of your urologist are good, you know. The hospital out there in the suburbs, boy, it's a beautiful hospital. She goes, you got to come into the city, the gritty Philadelphia city, and take advantage of the expertise that is there. So my wife and I talked about it, and we said, okay, I think we need to follow that advice. Again, not a disparagement of where I'd been. That helped me. That was my discovery phase. But now I needed a care phase, and I think I needed to bring it to a higher level. So we had that discussion with her. I had a subsequent discussion, so it was a Tuesday. And on Tuesday, she said, we're talking about it, and she goes, okay, you ready? So I'm ready. Let's get it going. She goes, all right. I've been doing some work. I have you set up for an appointment this Thursday with the head of surgery at Fox Chase Cancer Center, one of the top cancer, places in the city of Philadelphia. And this guy's the head of surgery, one of the best in the whole country. So back to that topic, you got to get into the city, you got to get the expertise. She helped me get to the best surgeon in the city of Philadelphia. And she goes, okay, that's Tuesday, that's Thursday. Now you go and see him, and if everything works out, he has all your scans, he's looked at all your charts. She said, if that's good, he's already planned surgery for you. So the next Tuesday, he's going to do a nephrectomy in the morning, and then he's going to take a break, have a beer, and then come back and do yours in the afternoon. I said, all right. So you talk about drinking out of a fire hose. That was drinking out of a fire hose. From Tuesday, having a discussion, Thursday having an appointment, and the following Tuesday having a nephrectomy. Jesus Christ. I mean, it was intense. It was intense. So anyway, we'll get a little bit more into that. But then back to the team Manning. I kind of developed, my mental team, and I just thought I'd run through it a little bit with you. Number one, as it always is your family. My wife, Kathleen, has been my rock. She's there at every appointment. Every up, every down, not too many ups, a lot of downs. She helps keep the thing moving. And my kids and my extended family and all the people that came to eat the meal yesterday, they're all there for me. And that's always, and I'm sure it is for everybody in this room, your family is the number one member of the team. The number two one was my friend from the medical community. She helped me get in and get the right care. And there's a third one that'll come up a little bit down the road was I have a friend who, of all things, is a oncology oncology sales director for GlaxoSmithKline, which is the big drug manufacturer for the oncology world. So I had a guy that I could go to and have some conversation off the record, you know, and give me the straight scoop. I also had two friends that were going through cancer at the time, one of them at Fox Chase. And I spent a lot of time talking to them, finding out what's the life of a cancer patient, because I did not know what it was. I had no sense. And then I guess the final part, and a very vital part of it to me today, is the advocacy community. I've become very involved in that. Loved hearing Laura talk about Kidney Can. That's one of my passions. We've been talking to lobbying the government for years. I've been with that about 5 years. But the advocacy opportunities of kidney cancer are tenfold what they were in 2015. And we all need to be a part of that. And we need to take everybody we meet in that community and take advantage of their expertise. And because it's a big part, and it's the things that Judy does, Kidney Can, KCA, we have a lot of resources now, and they all need to be part of your teams. So anyway, team Manning has nothing to do with Peyton or Eli. Okay, next. The surgery years, plural. So, been involved now in kidney cancer for 10 years. I have never met anybody with the same situation that I have. Now, I'm sure there are people out there, but I have never met anybody that's gone through what I went through. In 2015, so that Tuesday I showed up, I got the surgery, and it was a pretty big tumor, 10 centimeter, and it also had vena cava impact going up the arteries heading to my heart. So it was pretty serious. But we had a great team at Fox Chase. They got in, but it's, in 2015, it was major surgery. They open you up and fillet you out. And I asked the doctor, now, what do you do with everything in there? He goes, well, we put it over here and over here and over here. I said, now, who makes sure you put it all back? And that's what I want to know. Well, he goes, well, we take one thing out we don't put back, and that's your kidney. But it was successful, and in the follow-up to the surgery, we met with the surgeon and shook my hand, looked me right in the eye and says, no evidence of disease. What a term, what a term. Because it's a great term, but it's a real crappy term too, if it doesn't hold. And so anyway, but I'd whipped it and I went out and I healed up and I started working again, started traveling for my job, and everything was going pretty good. So I was on a 3-month cycle of scans. So I did four cycles. So the fourth cycle, after that, 1 year, almost exactly 1 year later. In fact, I think this week was that week where I was initially diagnosed in 2015. It was August of 2015. So anyway, 1 year later, I'm back there at the surgeon's office. He says, Mark, got to do the surgery again. I go, well, nothing's there. He goes, well, in the kidney bed down there, it's growing back. There's stuff we got to go in and get out of there, because as I was learning, and at that time, there was only two two avenues for a kidney cancer patient. It's extraction or it's some sort of drug therapy that, because, I wasn't in there with questions. So when does my chemo start? Well, no, we don't do chemo. No. It's not on the list. So opened me back up, put all the parts on the side, went in, scraped it out, sewed me back up. I came back in to see him, a few weeks later, shook my hand, says, no evidence of disease. Congratulations. Yeah. This Ned guy, I don't like Ned. He has not been good to me. So anyway, that was 1 year later. Well, I got quite an extension the third time. So I got 15 months instead of 12 months. Something showed up in the scan. They're visiting the doctor. He goes, guess what? We got to do another surgery. So in February of 2018, I went back in and they did another surgery. This time, it had grown into the wall of the kidney bed. So they went in, scraped it all out. And, he said in the follow-up that, it was a successful surgery, no evidence of disease. Thank you, not so much. He goes, but at the same time, we'd like you to consider a clinical trial. And the clinical trial was specifically addressed to recurrence. And he goes, boy, you are patient A as far as I'm concerned for recurrence. It just keeps coming back and coming back. And kidney cancer is vicious, as many of us know in this room. It does keep coming back and coming back. And we got to learn to keep fighting it. But anyway, he said, go home and heal up, and then you'll come in and get a scan, because to enter the clinical trial, you had to have a baseline of no cancer. So I went home, healed up. A couple months later, went in the hospital. Here I am. Okay, what do we want to do? He goes, okay, we're going to scan you, and then we have this paperwork you need to fill out. So I was there. I got scanned, filled all the paperwork out. But I was optimistic. I'm driving home and I'm going, there's a lot of stuff going on. I don't know all the answers, but I'm going to be part of something that maybe will find some answers. And that was very important to me. By the time I got home, I had a call. And the call was from the nurse who signed me up for the clinical trial. She goes, Mr. Manning, how you doing? I said, great. Good to see you today. Looking forward to the trial. She goes, well, I got some bad news. You can't join the clinical trial. And I said, why is that? They said, well, you have cancer. I said, no, I just had an operation. They scraped it out. She said, no, there's now 3 tumors in your right lung. And that was a pretty low point, because, it's one thing to go through these surgeries, but at least it gives you an optimism that they've tackled it and they've scraped it out of there. And now they can't take my lung out. So that was tough. And it was actually tough not to hear it in a formal fashion sitting across from your doctor either. She was just doing her job, but to me, that was a crappy call. To get a phone call to say, I'm sorry you got cancer again, congratulations. It was tough. But, life goes on and we get knocked down and we stand back up, and I had my team, I had my wife and my family beside me, and I said, we're going to keep going. So since that went away, now we're into the drug treatment path. And that had its own its own little story. So when you're going to a surgeon and he's your doctor, it's pretty great because you're with a guy, he's got a lot of expertise, And then what happens is I went to see him and he goes, okay, now, because after that, I went back to him as a follow-up to that phone call. And he said, all right, you're going to need to start, down either an immunotherapy or a drug path, and I said, okay, so what do we need to do? He goes, well, I'm transferring you. I said, you're transferring? You're my doctor. He goes, well, no, I'm the surgeon. Now you need to see an oncologist. I said, well, is he a good one? He goes, oh yeah, he's a good one. So we went in to see this oncologist there. And we had a lot of dialogue. We talked about immunotherapies. We talked about drug therapies. And I'd been starting to do some research on the drug therapy side. I'd been talking to my friend from Glaxo that knew about all the drug options that were in the space. And, I was getting some familiarity. But like at the end of our meeting with the doctor, with my wife and I, he gives us 2 pamphlets. And he goes, okay, here's immunotherapy and here's drugs. I want you to go home, read these, and come back and tell me what you want to do. And we took them and we walked out and we got in the car and my head was exploding. I said, did you hear what I just heard, Kath? I mean, I don't know if I got any guidance there. He told me to read and figure out what I want to do. I need something more back to give me some confidence that I'm making the right decision, because I didn't have confidence at that point. So that kind of triggered some things. He was also pushing for, on the drug thing, he was pushing for sunitinib. And I had that discussion with my friend from Glaxo, and he said, oh, Mark, stay away from that one. That's nasty stuff. And he had told me to think about a drug called Votrient. But what that interaction triggered was a desire for a second opinion. And at this stage, after these 10 years, I'm a big believer in it. I know Joel is always talking about that on his group, about the importance of second opinions and how it is part of what we need to do to understand our disease. And it's not a threat nor a degradation of anything any doctor has done. It's just part of the process. Would you agree, Joel? 100%. Yeah. So I went and got another opinion. And across the river from Philadelphia, there's MDA Cooper. Well, in my naivety, I thought I was going to MD Anderson, but I was going to MDA Cooper. A great hospital with great doctors. I got hooked up with a good young oncologist there that had studied kidney cancer at Penn under some great teachers there. He actually brought me, when we started talking about the drug options, he brought up what my friend from Glaxo brought up, is that, no, we want to stay away from sunitinib. Let's look at this Votrient. That seems to be a really good path for you to go on. So we switched. We left Fox Chase. We went over to MDA Cooper, and it was initially a very, very good experience there. We started on Votrient. It lasted 18 months. Votrient came with a good number of side effects. I mean, it wasn't perfect. Had a lot of appetite issues. had a lot of diarrhea issues. The big D is the thing all of us in this room battle usually. Lost about 35 pounds of salesman weight, well needed. Some people might have told me. But the scan at 18 months showed progression. So we needed to find another drug. And so the doctor there, he said there's this other drug that's just been coming on here in the last year or so called Cabometyx that has a really good reputation. It's the initial, the trials were good, and now the initial feedback from patient usage is pretty good. So I hopped on the Cabo train, and that was in February of 2020. And I'm still on Cabo, 5.5 years later. It's really been a great success story. Not without its side effects, but it did what Cabo typically does, which takes the initial tumor and reduces and then brings stable, and to me, stable is the new normal. If I go back in there and I get normal or stable, I feel like it's been a pretty good scan, But the one thing that happened about a year into Cabo is that great young doctor I was seeing took another big highfalutin job in another state, and I got transferred again, which is fine. I was in business for 43 years, and I got moved around under different managers because of things that happen. You got to learn to work with it. So I said, I'll work with this. So I actually went into the head of the oncology department. But what I really discovered there at MDA was they weren't MD Anderson. They were a wonderful hospital, Cooper, with good oncologists, but it was general oncology. It was not RCC specific oncology. And also, with that doctor leaving, they became very overwhelmed from the patient perspective. So, as a patient, you get that scan done, and you want an answer, And we always talk about, do you read your portal? Do you not read your portal? Well, the situation I ended up with at Cooper was I would go get my blood work local at home. Then I'd go in there and get a scan. But then sometimes it would be 2, maybe 3 weeks before I could see a doctor to discuss my scan. And that is hell. We all have a term called scanxiety, right? And that is scanxiety at its worst. When you want to know what's going on. Okay, they took the picture. What's the answer? Oh, just go home and relax. Relax. So, and then sometimes, just because of demand there, I didn't even get to see the doctor. My scan results review was done with the PA, which she was a very nice lady, very professional, knew her stuff. But to me, I walked out and I said I didn't see the doctor. I saw somebody that works with the doctor, and he told her what to say to me, for the most part. And so that led to another decision point. And it's probably a decision point to go the way that Joel espouses. You got to get to an RCC hospital. You need to get to the best care you can get. And probably, so that was 21. It was 6 years after I should have been there is the way I look at it. But if I knew then what I know now, and So anyway, we moved over to the University of Pennsylvania. And I got hooked up with one of the most outstanding doctors in the whole field. She's a teacher. But more than anything, from a pure patient perspective, I go in at 7:30, I get my blood work. I go in at 9 down the hall, and I get my scan, and I go upstairs at 11, and I meet with her. So it's bang, bang, bang. I don't spend weeks it's hard to explain. I mean, maybe you've had some versions of this, but to me that was incredibly mentally straining, to be sitting there wondering, what the hell's going on? You know, what did they find? And then lots of times, oh, stable, great. But, you know, why did I have to spend the last 3 weeks not sleeping, you know, worried about, you know, because I knew about Ned. Don't like Ned. So anyway, I'm still on Cabo. It's been great. Cabo has its side effects. Cabo has its financial challenges because it's a pill, not an infusion. If you're on Medicare, as many of us are, infusions are covered by Medicare. Pills aren't. So then you get into Plan D and the donut, filling the donut, and all that stuff Medicare people have to do. And Cabo's a big, big cost. I think Exelixis, as the manufacturer, they have a program that I was able to get some scholarships to pay for that, you know. So now I'm back on scholarship. Wow. I feel like the freshman. But, you know, you got to work to get yourself through the financial burden. And there's ways to do it. But it takes time, and it takes a lot of effort. It takes a lot of effort. So anyway, that's kind of where I am today. Cabo. I hope I can stay on Cabo another 10 years, you know. But I think the statistics weren't good when I started. You know, they were about the same as Votrient statistics. But now the statistics are better because there's, as the doctors will tell you, there's more people taking it, there's more data out there. So we know it's not going to be a month or 12 months. It's going to be probably something more, you know. But I started down the path going, well, this will get me another year, you know. I mean, when I was a kid, we played kick the can. And that's what we're playing out there in the RCC world. Kick the can till the next thing is there to get us through. I just thought I'd leave you with this. Advocacy, which is this room, bunch of beautiful people doing a lot of really good things from a lot of ways, from the doctors to the different foundations. For me, now this is my menu. Everybody has their version of a menu. This is my menu. One, about 6 months into Cabo, I found, because you're just bumbling around, I found this Facebook group, Cabo Medics group. So I joined it, you know. And about 6 months in, the guy who was running it took a turn and eventually passed. And he asked me to be the admin. So we had about 500 people. Now we're up to almost 3,000 people in that group. And every morning I wake up and answer the questions that come my way. Kidney Can, as Laura talked about, great organization. Judy, our heart and soul right here. A lot of beautiful people doing a lot of great things. I very simply say when people ask me, what's Judy? Judy helps you for everything you need to know once you leave the doctor's office. You know, there's a lot of stuff going on. There's help for the caregivers. There's help for the diet. There's help in a lot of those unique ways that you don't get there in your 15-minute conversation. And then KCA, which is the mothership. You know, if you need to ever find a doctor, they have doctor referral things on there. It's a great organization. So, and there it is. And watch out for Ned.
Thank you so much, Mark, for sharing your story. And again, I think it highlights just the importance of advocacy and perseverance. So thank you. Now I'd like to introduce Dr. Paul Viscuse. He is an assistant professor of hematology and oncology at University of Virginia Health, and he will be discussing emerging immunotherapy options.
So thank you for the invitation to speak today. When I was in medical school, my cousin, who was like a brother to me, had advanced kidney cancer, and that's what led me to choose a career in genitourinary oncology. So speaking to this group is really truly a privilege for me. So thanks for the invitation. I got asked to speak about emerging immunotherapy, and I hope this addresses some of the questions that came up about the horizon and some of these durable responses we're all seeking. I kind of structured the talk. It's going to focus more on the clear cell, the more common variety. There was going to be a talk later on the more rare variant. I wanted to start with how is immunotherapy currently being used to treat kidney cancer? Some of that was touched on earlier. And then that way we could easily pivot to what are some of the emerging therapies being looked at in the immunotherapy space. We should put it in the context of the stage of the disease. The bulk of this talk will be on stage 4 disease, which is metastatic advanced kidney cancer on the right. Stages 1 and 2 are limited to the kidney. Stage 1, less than 7 centimeters. Stage 2, over 7 centimeters. These are oftentimes cured with surgery alone, though not always. And then stage 3, we'll touch on briefly. Dr. O'Malley did a nice job touching on this with adjuvant treatment, but I will make brief mention because it has some relevance to the talk. These are where the tumor's starting to break out of the capsule into the surrounding fat or invade the renal vein. And then stage 4, which is when it gets out of that kidney, goes to other distant sites like the lungs, the lymph nodes, bone, liver. So metastatic kidney cancer treatment, we do have options. So when someone's diagnosed with metastatic kidney cancer, that can mean a lot of things. Maybe they had a surgery in the past and then it recurred, like we heard about Mark's story. Maybe when they first heard that they had kidney cancer, they had metastatic disease in a distant organ. So this varies our approach, and we should take it case by case. I do agree with second opinion in a lot of these cases. So what can we do? In some cases, we can actually do active surveillance. There's clinical trial data that was run that showed that in some cases, we can watch it. That sounds uncomfortable, but it delays the time to start systemic treatments, which have their toxicities. Maybe it's in a couple of sites, it's slow growing, and we can access that with a surgery, I can never say the word, metastasectomy, or focal radiation to try and, again, delay the time needing systemic treatment. But ultimately, most of these cases are going to require some form of systemic therapy. And the backbone of that systemic therapy that goes head to toe, is immunotherapy in today's kidney cancer landscape. Currently, when I say immunotherapy in terms of approved agents in kidney cancer, I'm referring to immune checkpoint inhibitors. When I describe this to patients in my clinic, I say it's like taking the camouflage off the cancer so that your body can fight it. We were built with an immune system to get rid of abnormal cells, and for some reason this cancer is hiding from it. So the idea is to block these checkpoints, which are kind of receptors that interact between the tumor and the immune cell. It's a don't kill me signal. We block that so it does kill it. And the approved drugs that first came out for kidney cancer, the seminal study was the Checkmate 214 study of ipilimumab and nivolumab, which showed a significant survival benefit compared to the standard of care at the time, which was sunitinib. Oops. And so we see that we have a lot of experience now coming off this study. Initially, when they put out the data for it, about 40% of people had a response, so it shrank on a scan. An additional 30% had stable disease, just as good, I agree. And when we look at the long-term follow-up, this is the real kicker, is if you had a response, even at 90 months, half those people are still in a response. And let's keep in mind that this treatment regimen stops after 2 years if you're otherwise tolerating it without toxicity. Or sometimes you have to come off of it because of toxicity and the disease stays put. And so it's that durability of response which is really the thing we strive for with immunotherapy that we don't always see with some of the other modalities. I need to make brief mention of the VEGF tyrosine kinase inhibitors, these targeted drug therapies, because they are being looked at with immune checkpoint inhibitors. My arrows are all messed up. But it's axitinib is one, cabozantinib we heard about, and lenvatinib. And these target the blood vessel growth to the tumor, anti-angiogenesis inhibitors, and they're pills, they target. And it was said, well, okay, we have two immune drugs combined, seems really good frontline. What if we combine a pill with one of those immune drugs frontline? And several studies looked at this. You have pembrolizumab, axitinib, nivolumab, cabozantinib, lenvatinib, pembrolizumab, and these studies showed that frontline has significant survival benefit compared to the standard of care at the time, which was sunitinib. These are also very reasonable options in the front line. There was a question about when do you call these drugs a cure? When I give ipilimumab, nivolumab to someone, I do think of it in my mind as curative intent. But what I tell the patient is, we have data that says you have about a 20% chance of not responding to this, but a 20% chance of still being in a response many, many years later. And you can interpret that as a cure if you like. In my mind, that's pretty good. So with these regimens, the challenge is you have to stay on the pill. But the nice thing about these regimens is if someone's really sick up front and you think you have one good chance on goal and you need a response, these are more likely to get that response up front. So this is where I sometimes leverage these regimens as well. Any of these are good. It's always what is the right treatment for the right patient. So we have a good amount of options in the frontline space. I'm going to come back to that. I just wanted to briefly mention high-risk disease. So you have localized disease, get the kidney out. It has high risk for recurrence. Maybe it's getting out of the capsule, it's invading the vein. Maybe under the microscope it has a high grade, meaning it has a real messy look to it. We know these patients, we saw it with Dr. O'Malley's talk, that they have a high risk for recurrence. And so the Keynote 564 study did show that 1 year of pembrolizumab seems to improve survival in the overall population. I agree with what was said that these are probably more of the higher risk patients, but it should be a discussion with the oncologist after your surgery. Am I an appropriate patient for this regimen? Now this is always a challenge because we don't see cancer on the scan, so giving someone immunotherapy when they may be cured as they sit there is always uncomfortable as an oncologist as well. So these are tough discussions, but a discussion we should have, and just to show that there was a survival benefit. Though modest, it is there, which we didn't see on any of the other immune-based adjuvant studies to date. And I'll come back to that in terms of some emerging options that were briefly mentioned. This all sounds great, and it is, but there are patients who do not respond to these regimens. Or maybe they responded and now they're progressing after that initial response. Current standard of care would dictate that we give targeted drugs like a cabozantinib, VEGF TKIs, mTOR inhibitors. There's a newer pill called belzutifan that's approved in the salvage space that targets something called HIF-2 alpha. And these are all nice options. They don't typically maintain a durable response, though I stand corrected after hearing some stories that were presented here, which is excellent. But in the majority of patients, they develop resistance to these drugs and don't see that same durability like we do with the immune-based treatments. So, and someone asked about, can we go back to immune-based treatments after progression? Well, we have two large clinical trials that say no. The CONTACT-3 with cabozantinib atezolizumab versus cabo alone after progression on immune checkpoint inhibitor, and then we heard about the T-NIVO2 study. So these two big phase 3 studies said patients do not benefit or live longer if they get immune checkpoint inhibitor after progressing on it in the past. So this is an area of unmet need. So now I'm going to pivot into where are we headed? Well, and I thought it'd be easiest if I kind of do broad strokes of types of treatments and then give you a little samples of like examples of RCC-specific options. And all of this is still under study. None of this is FDA approved that I'm talking about today. Other immune checkpoint inhibitors, I mentioned that PD-1 and CTLA-4, which is ipilimumab and nivolumab. And then there's others as well, like pembrolizumab, avelumab, and such. But what about other checkpoint inhibitors? LAG-3, for example. This is a checkpoint that has made a lot of headway in melanoma. There's a drug called relatlimab that's FDA approved in melanoma, has improved survival and outcomes. So what about in kidney cancer? Kidney cancer kind of got to immune therapy just after melanoma. Melanoma kind of set the stage. So could we do that with LAG-3 inhibitor? In fact, this is being studied. There's a phase 2 study that reported, the fraction study, showed some efficacy with this drug in combination with one of the other immune drugs, nivolumab, but also is now being studied in the front line in combination with ipilimumab and nivolumab compared to ipi-nivo alone, to see if triplet, we heard about maybe we need to up the ante up front. This is trying to do that with a triplet option versus a doublet option so we can improve those durable outcomes that we're hoping are cure-like. And then there's a more novel LAG-3 inhibitor that's being looked at on a study called the Keymaker study, and it's looking at that in combination with one of those TKI and immunotherapy combinations I mentioned, which is lenvatinib and pembrolizumab. So can we combine another immune drug to the immune TKI combination up front and improve those outcomes? Another checkpoint worth mentioning here is the TIGIT, which is always fun to say. TIGIT, there's a couple drugs looking at this. One in particular, again on that Keymaker, big umbrella study, well designed, looking at an anti-TIGIT molecule in combination with pembrolizumab and one of those HIF-2 alpha drugs I mentioned, the belzutifan, and to see if that improves outcomes up front. So again, intensifying treatment up front with more checkpoint inhibition is one option. But we know that taking the checkpoint off, releasing the brakes from the immune system is not specific to the tumor and can present with significant toxicity and danger, as many can maybe attest to here. So what about trying to hone that immune system towards the tumor? One way to try and do that is with chimeric antigen receptor cellular therapies. It was asked, what's the next avenue to try to get these durable responses and cures? In blood-based cancers like lymphomas, multiple myeloma, these CAR T therapies or CAR NK therapies have led to these same durable cure-like responses. Can we get that to solid tumor? It's been a huge engineering challenge, but we're getting there. In kidney cancer, I should say what a CAR is. So you have an immune cell. We take a receptor that you normally find on a B cell that's specific for a certain bug or antigen that you don't want in your body and does immune surveillance. We engineer a T cell with that receptor that targets something specific to the tumor. And then the idea being that T cell is really revved up, specific to that tumor, and when it binds, it goes crazy on the tumor. So targeted immune therapy. I have a couple molecules listed here that are under study at various phases. The one that's probably made the most gain that's relevant to talk about today is CD70. CD70, there's two molecules that are kind of making headway here. One was presented a while back on the Cobalt study, small phase 1, but saw that when you consider disease control rate, which is stable disease or response, because stable disease is just as good, the disease control rate was above 70%. And they had one responder that they recently presented at one of the conferences that's still in a response 3 years later. And these, because someone asked about, well, what if they've had several lines of treatment? Patients on this study had many lines of treatment on average. This wasn't front line. So these are people who were refractory and are having complete durable response. So very exciting. And then there's another CD70-based molecule that in a phase 1 that was recently presented at the ASCO conference we were at in Chicago. Traverse study showed about a third of patients had some kind of response, and a few of those responders are durable. They've looked about a year out and are still responding. So this is exciting. And again, very treatment refractory disease, patients who have experienced a lot of different treatments up front. Another way to try to target the immune system towards the tumor in particular is with these bispecific T-cell engagers, BiTEs. I like to think of these like Velcro. You have one side of the molecule grabs the tumor cell, and another side of the molecule grabs the immune cell and makes them meet and brings them together to stimulate an immune response. These types of drugs have had significant success in other tumor types, leukemias in particular, and most recently in small cell lung cancer, which was considered a very refractory, didn't have great treatments, now has an FDA-approved BiTE that has led to significant gains. How do we bring that to kidney cancer? Here's a few many molecules under study. I'll mention one, full disclosure, I'm a little biased because we have it open at UVA with a company called Regeneron, but it's a BiTE that targets a molecule called PSMA, or prostate-specific membrane antigen. You're probably saying, Paul, that's great, but it's not a prostate cancer group, this is a kidney cancer group. I get it, but that molecule, believe it or not, it's not that prostate-specific, it's on clear cell kidney cancer. So the idea being, can this molecule be effective for patients with kidney cancer? And so we're looking at that in patients who have been refractory on multiple lines of therapy. And there are others. There's ENPP3 and other targets. So another exciting avenue. I'll close with neoantigen vaccines. This was mentioned already, but just to highlight, because it is a cool job done by Dr. Braun and his colleagues up at Yale. Vaccines, when I was doing my master's degree, I wrote about immunotherapy and kidney cancer, and I really thought this was the avenue, because at the time all we had was sunitinib, and I felt like we needed that chance for cure. And vaccines really promised that. The technology to date has been very disappointing. This new idea of neoantigen vaccines that leverages our ability to sequence DNA, RNA very quickly is an excellent idea. They had 9 patients who had high-risk cancer, got that cancer removed with NET on the scan, and they saw that when they sequenced the DNA of that tumor, the DNA, the RNA, they highlighted tumor-specific antigens, peptides, what we call neoantigens, and made a vaccine of it, and gave that to the patient in combination with immunotherapy. And all 9 of those patients are still without evidence of the disease. Now, it's only 9 patients. Maybe they were all cured with surgery, but that is very intriguing, and they're going to design that to a bigger phase 2 now. So these are all like very exciting options. I want to close with this idea, sometimes clinical trials, and I'm a clinical trialist by trade, the thinking is, well, I'm going to exhaust everything and then I'm going to go for a clinical trial. And there's certainly a role for that. We have a phase 1 group at UVA that, looks at, we're testing new molecules when all else fails. But keep in mind that not all clinical trials have to be at the end. They could be at any stage of the disease. I mentioned some frontline trial options. So I would encourage you at every stage of the journey, if there's going to be a change in the strategy, ask, are there trials for me? If you're wondering and the doctor's not sure, certainly come see one of us at a tertiary center, or the KCA has a great clinical trial finder on their website where you could search by tumor type. So if you have papillary, you can punch in papillary, Virginia, and it'll show them out and where they're located. So please always think of clinical trials. It's the safest, most effective way to take care of people. And I thank you for your time today.
Chart in the beginning that had the 48%. I've never seen that one before. I've seen them all.
So what this is,
what does the 48% represent?
that's
on the top, I see it. I see the tail. So what's that 48% represent? I've never seen a number that high.
So the reason it looks high is these are limited to those patients who had a response.
Bingo.
Yeah.
Okay, so that changes to me everything, because I've never seen that. So if you've had a response, what we're saying there, and I think this is good for this group, if you've had a response, there's a 50-50 chance you're at that's year number 8. I mean, that's
Correct.
A huge number.
Now, statistically, it always gets challenging. The further you get out in years, you have less patients to measure. So what we call censoring. People drop off, they go on with their lives. So sometimes as you get further out, that number gets harder to interpret. But certainly with that tail, it is very intriguing. And so, yeah, if you have a response, it's very promising. The challenge is what this contains is about 40% of the people who were on the initial study who had a response.
Gotcha.
So that's why it looks better than most think. What I always say is 20% progress outright, don't see a benefit. 20% who get could be in this bucket where they're 90. So I do word it that way. And that's why when I give this treatment, in my mind, my goal is to try and quote unquote cure that patient.
Well, I love that chart because really that's key. So if your oncologist says you've had a response 2 years out, now look how the odds change for you. Now you got a 50-50 chance maybe of being here in another 6-7 years.
Correct.
That's huge.
And that's off treatment.
And maybe even, I know they hate the word, being cured.
Correct.
So one other question, and then I'll let you go, just because I'm on Yervoy Opdivo. I'm still on Opdivo. Have you ever had a case where you're on Opdivo and they add Cabo with the Opdivo after? I had some liver progression. They deemed it an oleo progression. I've never come across anyone but me that's been on, it's normally Opdivo Cabo. I had Opdivo Yervoy, and about a year later, they said, what the hell, let's add Cabo to the Opdivo.
So-
Have you ever had that situation?
So it's changed a little bit with the new landscape. We used to, before we had some of the newer studies that showed us that, because remember I mentioned there's 2 large-scale studies that show clearly keeping immunotherapy going or adding it back after progression doesn't help. But we used to always do it. There's still people who probably do it because we would like to hold on to it, especially if someone's tolerating it really well. But we know it doesn't work. So, but maybe then we didn't know. So that's very reasonable to say, hey, someone's been on this long term, something's working, let me add the Cabo, which we know is an active drug. I would argue now with the way the trials have read out and what we know about the landscape, I would stop the immune treatment at that point and start cabozantinib as monotherapy.
If you're tolerating both, is there really a downside to having both? If you're tolerating both with no toxicity?
The trial would suggest there is, because the trials that showed no benefit also showed potential harm. Now you could say, well, my chance at and it depends how long you're into it, but it would be a discussion. I would never no, you can't have this, but the data does suggest that continuing that immune drug doesn't seem to benefit.
How often do you recommend that people that are responding go more than 2 years on the Opdivo? Because that's the other thing out there. You hear a lot of people saying after 2 years, that's it. If it's working, you don't need it. And I see a lot of oncologists that say, hey, it's working, so let's just, as long as the insurance approves it, let's keep going. Do you have a viewpoint on going more than 2 years on the Opdivo?
So it's a great question. I don't blame those who want to stay on it. I can't imagine what it's like to be in that chair, having gone 2 years, and now we're going to stop. That's got to be very, that's a tough call. But as a clinical trialist and a physician, when I look at this, these patients came off at 2 years. When they ran this study, they had to come off at 2 years, mandated by the protocol. And they're still in a response. So that tells me we don't need to continue that. Yeah. So I do stop it at 2 years. Yeah, I do. Yeah. That's the reason I put people on this regimen, because the idea of treatment-free survival, coming off of treatment altogether. So that's how I tend to do it.
But the interesting question is, Keytruda was approved with a 2-year stop date. Opdivo wasn't, and I'm always curious why. So I was on Opdivo for 4.5 years, and I was not about to stop it because my side effects were manageable. I had oligo progression. I felt it kept me alive. And I find it fascinating that Keytruda has the 2-year stop, very clear. Opdivo doesn't. So that's just interesting as a patient.
Oh, no. Again, if the trial was designed to keep it going, there are, like I take care of bladder cancer, sometimes this comes up, and it's a discussion with the patient. But the whole reason why I like a combo immune drug combination without the TKI is this idea we can come off treatment altogether. Now, if the patient doesn't want to and we can get it approved and they feel it's of benefit, I'm not going to try and strong arm someone off it. But that is, this data shows that you can. Yeah.
I would just say the one thing is, we haven't seen it yet, is that patients who are on these treatments for longer, it hasn't been made an exclusionary criteria for clinical trials, but it may in the future, right? So right now, if you had 2 years or 4 years and you've had progression, they'll let you on the new clinical trial. But it may be that in the future they'll say, you have had to have had 2 years, but you can't have had more than that. They haven't made that yet, but it may come in the future.
That's a good point. And some of the studies I mentioned with these emerging therapies do have some of that built in. So that's a great point.
Hey, I've got a question about the opposite. What if you had Cabo, Opdivo first line and you failed it for Cabo toxicity to go to Ipi-Nivo?
Two things there. Ipi-Nivo as a salvage combo, the Ipi doesn't seem to add anything. And we've looked at that on multiple trials where, what if we start with one immune type regimen and then we come in with Ipi later if it's not working? The results are really dismal. So I would not add Ipi-Nivo as a salvage. But to your point, if someone if someone came off immune treatment, but it turns out in retrospect, maybe it wasn't due to the immune drug toxicity, but due to the TKI, and they didn't clearly have progression of their disease on that immune drug, you can make an argument to re-challenge. I think that's very reasonable. Oh, please.
I have papillary cell. I've been on Opdivo and Cabo for cruising into about 5 years now. And I was told at first it would be 2 years on the Opdivo. And then when I got to that point, I was, like you said, in the chair, like, I'm on number 24. And then they said, well, why would we take you off? Another doctor said, it's working, we'll just keep you on it. Now I've had some progression, so they upped my Cabo again. So now I'm back on a higher dose of Cabo. And I was wondering, since you're talking about things in the future, and I know there's a lot of things in the future for clear cell, can you tell me, is there anything you can throw out here to papillary cell that may be coming down? The first gentleman mentioned avlutinib and the Antinib. Is that a combination that's for papillary?
That wouldn't be a combination I would think of in your case, where some of the, and I don't want to step on the upcoming talk on these, but there is some work being done more so in variant histologies now, which is excellent, because when I was going through training, it was non-clear cell, which I hate that term because it's just a bucket term, and we studied them as a bucket, and it's a bad thing to do because they're very different. They're finally starting to get the attention they need. From an immune standpoint, that's been tough because traditionally these have been considered not too immune responsive, but that has changed because we've had some studies now come out, at least in the front line, to show benefit with immune treatments. There was a study called the Sunny Forecast that showed Ipi-Nivo benefits some of these patients who have papillary chromophobe and some of these other ones. So I think the mindset's changing, and therefore I hope that some of these immune-based treatments that we spoke about today start making their way to papillaries and beyond. Unfortunately, I worry it's going to follow the typical trajectory of, well, let's make sure it works in clear cell first, and then we do it in papillary, and it gets, delayed in that way.
What would you say, because my chances are I'm probably going to end up having to change these meds. I go back in September to MDA for scans, so I'll know a lot then. But what would you say, if that's been my first line of treatment for a long time, I've tried to hang on to it because there isn't a lot of things waiting for me, and I want to not use everything up. Is there anything that you would suggest? I know you're not my oncologist, but what would be another combo that would, if I had to go to second line?
There is some, so not immune-based, but there are other agents being studied in this space. I know Exelixis is doing work in this with their Zanza, which is a targeted, hopefully, Cabo 2.0 drug. That may be an option for you going forward if that shows that it's effective on the study.
What was that called?
Oh, God, I can't spell it. That one. We call it Zanza whenever I meet with Nick. I call it Zanza.
Have Nick spell it later.
So. So that's being studied on a trial. There's other molecules being studied on the trial, not immune focused per se. So I'll be honest, the landscape has changed a little bit. For folks with variant histology, I would encourage you to go on. KC Cure has a nice non-clear cell focused clinical trial finder. And so that's a good way to look at it. But if you're at MD Anderson, I mean, they're going to, that's where I trained. They have plenty, that's the land of non-clear cell. So they're going to have plenty of trials, hopefully, in that space to inform you.
I'm just trying to prepare myself, and so I can go in there a little smarter.
I think looking at those clinical trial finders, that's what I instruct because we don't have great variant trials right now at UVA, admittedly, so hoping to change that. But there are good, like KC Cure has a great clinical trial finder that's specific to variant histology. I think that'd be a good place to start.
Thank you very much.
Of course.
Hi, good afternoon. My question is from IDMC's risk categories, where do you see that? Do you see that going away in the trials or still playing a role? My reason is because I'm clear cell, low tumor burden, favorable risk. I almost didn't get Ipi-Nivo. Had it not that NCCN guidelines hadn't been approved 6 months or like 3 months earlier, they wouldn't have given it to me. I would have had to go on a TKI, and that's not where I wanted to start. So
yeah, to first point of that question, are we still using it? Yes, unfortunately, it's the best tool we have. Very rudimentary tool, but somehow it's still relevant even in the immune checkpoint days. We looked at that, and it's still relevant in terms of prognostic, meaning can it give us a sense of how someone's going to do in terms of long-term outcomes? But what it's not great at doing is predicting response to treatment. I give it, even before even when NCCN was against it, I gave Ipi/Nivo to favorable risk. Because when I was at MD Anderson, they were running this study, and one of the main authors on there was my mentor, and they were seeing that favorable, because initially they had favorable risk on until they changed the design in their WISM. And that showed that a lot of these long-term responders were favorable risk. So I do think, and now we've shown that some of the studies that have the immune drug with the pill, initially it looked like, well, their favorable risks did better, but now it's tightened with time, because that's what happens is favorable risk, you do well regardless of what we give to you. So it's going to take longer for you to see that tightening of the curve. So to me, they're all good for all risk types. I'm an Ipi/Nivo guy full-fledged because of that opportunity to come off treatment, but they're all good. If you have a doctor who's good at giving one of them, that's what you want. But great question. All right, thank you.
Thank you so much, Dr. Viscuse. And I just wanted to do a quick reminder that not only will this symposium be posted onto the Judy Nicholson YouTube page, but I see some of you taking pictures, which is great. Please continue to do that. If you'd be so kind as to tag us on social media, we'd appreciate that as well, if you're posting these. But just a reminder that you can also watch this later on and share with anyone that's interested. And I just wanted to briefly thank Linda and the Judy Nicholson Foundation, because I go to a lot of cancer conferences as a patient advocate, and honestly, I think that we are the only ones, I would say this very boldly in the kidney cancer space, that allow this to be focused on patients and caregivers, getting this wonderful information from some of the top experts in our field, and also being able to engage in a really great dialogue. So thank you to the foundation for allowing this. I'd now like to introduce Dr. Logan Zemp. He's with Moffitt Cancer Center in Florida, and his clinical focus is management of urologic malignancies and kidney cancer. And he will be talking today about PET scans and the concerns and controversies in radiology. So buckle up. Thanks, Dr. Zemp.
All right. Well, it is truly a pleasure and an honor to be here with all of you. It has been so wonderful to sit down and chat with individuals in this room and get to know you and know your stories. So I am not a radiologist. I'm going to put that out there. That's like full disclosure here. But we're going to talk a little bit about imaging and kidney cancer, and we'll talk a little bit about some conventional imaging, and then specifically about some PET scans and some interesting things that are happening and may happen in the future. There's a couple of slides that I might just cut out. Just don't be alarmed if I skip through them very fast. But our uses in kidney cancer, really we're looking at primary, our uses of imaging is looking at the primary tumor and then doing a metastatic evaluation. And it also helps us as surgeons and as medical oncologists to make a determination on what the plan is going to be going forward. It also helps us, we've talked a lot about follow-up. Everybody gets their follow-up scans. And then there might be some opportunities for some therapy. So just some, the guidelines. These are AUA guidelines. These are NCCN guidelines. And these are our European counterparts. Really what it says, and I'll just shorten that down, is that you need some high-quality cross-sectional imaging with contrast to get a determination of at least the primary tumor. And most of you in this room have already kind of known this. These are just some pictures of two different types of kidney cancer. The top row is a clear cell kidney cancer in an unenhanced phase, then a nephrogenic, then a delayed phase. And this is just, you go through the scanner at, 90 seconds after you get your contrast. That will give you this image. This is a number of minutes after. And what we're looking for is this contrast enhancement. These, this looks different than this, suggestive of a contrast enhancing mass. This row down below is a papillary renal cell carcinoma, and we only know this because we have pathology on these. But this is a typical appearance, that it's a weakly enhancing. That's what your surgeon, your radiologist, that's what they're looking at. But to truly get a diagnosis, you need tissue. And so some of you may have gone through a kidney mass biopsy, and this is just how this is slightly done. You're in a CT scanner, you get some local anesthetic injected under the skin, then a sheath goes down, and then a biopsy gun takes multiple biopsies of the kidney. There's concerns for this, and I talk to many patients, and they're reasonable about the concern, like how good is a biopsy? Like if we get a biopsy, is it going to be accurate? And about 90% of the time it is, and it's better if you get more tissue. So that's what this core biopsy, the one with the star, it's really important for those rather than FNA. So that's one. Am I going to get a true answer? And sometimes you won't get an answer. It can be sampling error. It can be that heterogeneous part of kidney cancer that Dr. O'Malley was talking about. You can maybe get a biopsy that says it's not kidney cancer, and that can be frustrating for patients. And then there's the safety aspect. Is this safe? For the most part, I would say biopsies are quite safe, but you can get a little bit of bleeding from a biopsy. These are two pictures of, these two are the same patient. They had different looking masses, and so I wanted to get a biopsy. I got a call from radiology saying, we're not going to biopsy the other side. We biopsied one, and she started bleeding. So she didn't need a transfusion or anything, but you can get a little bit of bleeding, a little bit of blood in the urine. It's rare for a transfusion. This person didn't have a RCC, but he had upper tract urothelial carcinoma, and he had a pseudoaneurysm from the biopsy. It's just a weird abnormal connection between arteries and veins. That led to some issues. But the biggest thing that I think that you need to know in this room and in this group is, if you're talking to people and within the site, there's always this concern, well, if I get a biopsy, is it going to spread my cancer? That's a very common concern and question. And since they've moved to that biopsy technology that we showed in a couple slides ago, using the sarcoma sheath, seeding is not truly a concern. This was maybe years and years ago, but not in 2025. So I was here to talk about PET scans. So what does it say about PET scans? So these are those 3 guidelines. And I'm talking specifically about FDG PETs. That's the most common. That's usually what people are talking about. The cancerogram is one of the terms out there. So our guidelines say for routinely, we do not recommend to get a PET scan. That doesn't mean that PET scans might not be used, but just as like a upfront staging imaging, we typically don't recommend that you get a PET scan. And there's multiple organizations throughout the world that would suggest that. But what is a PET scan? So a radioactive sugar molecule is injected into the vein, so intravenously, and it gets taken up in active cells. Cancer cells are active cells. Inflammation and infection, also pretty active. So it gets brought into these active cells, glycolysis happens, and it gets trapped into this tumor cell. And then you have this detector that takes an image, and it shows up as hot spots. So it's kind of like an adjunct to the map that imaging is. It has some limitations. So physiologic excretion, and I'll show you, and I have some slides on that. It will decrease the ability for us to detect kidney masses in the kidney itself, and then it may obscure those lesions. You can get false positives from that infection and inflammation like I was talking about. But it actually does a pretty good job of finding metastases outside of the kidney. But it doesn't always add additional information that a CT scan might. So when I was making this talk, I don't know if I was like missing home. This picture is Waterton Lakes National Park in Alberta, Canada, looking down the lake to the glacier. And there's this really awesome map in the visitor center. And I was like, I have to have a picture of this thing. And I do. It's the only one I could find is my daughter Zoe looking at this map back here. But apparently I thought it was more interesting my other daughter Beth looking at like animal droppings, so I took a picture of that one. fortunately, the family was there. So, in the picture, the person was standing right here, looking down this lake, and this mountain right here is Mount Crandall. So, this topographical map, you could probably get a paper copy. You could walk down these trails. You could go see these lakes. This is Cameron Lake. But the nice thing about these topographical maps is if you press a button, it will show you exactly where you want to go. And that's kind of what I'm trying to show here, is my niece was pushing the button for this Crandall Mountain lookout, and also for Cameron Lake up here. So it will give us a little bit of a shot or an opportunity to look at maybe where those active cancer cells might be. The problem with PET scans, so let's say I had talked about physiologic excretion. That's just like a fancy doctor term for saying it shows up in the urine, so it makes it difficult for us to image, okay? So let's say, you got your FDG and it went into all these lakes. One, your eyes get drawn towards all these bright areas. And two, if I was looking at this Cameron Lake right at the top, it starts making it difficult for us to see that lesion right beside that area. Whereas that outlook that's totally separate, you can see that a little bit better. Hopefully that makes it a little bit clear why sometimes we often don't recommend PET scans for primary imaging. This is a patient of mine who got a PET scan a couple of months ago. He is like many of you. He had a large kidney tumor, and we removed it a couple of years ago. And we've been following his scans, and he had a CT scan that showed, a lesion in his lungs. And there was actually a couple of lesions. So this on the left, that was a lesion. That one's been there, and then he's had a lesion in the left lung over here. One shows up as hot, the larger one, and the other one shows up as not. So this helped us make a determination: is he going to get systemic therapy, or is he going to get like a surgical resection of that? And he's recovering from having the lower part of his left lung removed currently. So there's a number of different mechanisms that these PET scans can be used. I was going to talk a little bit about sestamibi scans and the use in something called oncocytomas, which are benign kidney lesions. But I might just kind of blow through this. Really, sestamibi, they're supposed to show up hot if it's benign, and cold if it's clear cell renal cell carcinoma. I'll just go to the tweet from Dr. Kudikoff at Fox Chase. He says, sestamibi wasn't so hot in our experience, and that's really what you need to know. Great tweet. And then PSMA, we've already kind of briefly touched on this. Yes, prostate-specific membrane antigen. Why are we talking about that? Because it's actually folate hydrolase, and it is expressed in the vasculature of the proximal tubule and in several solid renal tumors. So how good is this at detecting kidney cancer? It detected in about 74% of primary kidney lesions and 87% of metastatic or recurrent kidney cancer. So this is an imaging opportunity to find these masses. It's not something that's widely used, and right now it's just more clinical trial or investigatory. And then I wanted to talk about an additional marker that is found in about 95% of kidney cancers. It's called this carbanic anhydrase 9. And earlier this morning I was looking at some of my kidney cancer pathology that I need to review as a physician, and this is being called in many pathology reports because it is so frequent. So there's some opportunities there as we were talking about biomarkers and how could we target therapies. So there's this molecule called girentuximab, so it's a monoclonal antibody, and it has a high affinity for this marker for clear cell kidney cancer. The nice thing about this is this does not get excreted into the urine, so it doesn't you're able to image kidney cancer within the kidney itself, and then elsewhere it gets excreted through the liver. That's all that says. It's got a long storied history of safety going back to 1986. It's changed companies a number of times, and it's something that we're starting to look at and think about a little bit more. The first real study was this REDEX study, where they injected this iodine-labeled girentuximab, and so they injected it 4 to 5 days before somebody had their imaging, and then they went for they went for their partial nephrectomy or their total nephrectomy, and the imaging had a higher sensitivity and specificity, so it was better at detecting clear cell kidney cancer than conventional imaging. There are some problems with the iodine, and so they switched to zirconium. The problem was it could dehalogenate, meaning it could become dissociated, and then it was not as good. But then they did this zircon trial that's been reported in the last couple of years. Very similar concept. So they took 300 patients, and they had varying types of histologies. The majority of them were clear cell renal cell carcinoma. They injected this medication, did imaging 2 to 5 days later, and then within 3 months underwent a surgical resection. What they did is they took 3 separate radiology readers to see how good that this technology was. Their primary endpoint was, their sensitivity and specificity. How good is this? It might be hard to see. Yeah, it is a little bit hard to see. There's like a little spot up here in the window panel, a little tiny spot denoted by the arrow sign, which all people like to point it out. And then it shows up pretty, we'd call that hot. It has a high SUV number. Whereas this larger mass that was not clear cell renal cell carcinoma did not show up hot. It could have been something else. There was very low issues with getting this medication, low adverse events. Is really good, might help us pick up imaging in the future. So there is some interest in this. This was just something that came in my email last week that I wasn't really expecting when I was making this talk. It's just a survey request to see, how we are using this as a urologic oncology community. I didn't take the survey yet, by the way. I was too busy doing other stuff. All right, so hopefully people recognize this. Roads, where we're going, we don't need roads, right? Do we need this map? Do we need all those maps, all those surgical maps? Or is there something coming down the hatches in the future that we might be able to do or offer for patients? So there is a term, it's called theranostics. So really, I don't know who it was, but they just decided we're going to ram 2 words together, therapy and diagnostics. And they couldn't do it the other way around, I guess, because it would make more sense to do diagnostics than therapy, but whatever. So this is the idea, is that you have a cancer cell. In this scenario, let's call it renal cell carcinoma. You need a target or a receptor. You have something that is there 95% of the time, this carbonic anhydrase 9 or PSMA or something else. And then you have something that has high affinity. So in this scenario, let's say girentuximab. So what if we, instead of just doing something that would help us with some imaging like zirconium or iodine, what if we put a payload on that and we just annihilated that tumor with like lutetium or something like that? What if we did some targeted directed therapy to these cancer cells? And I think it's like a very novel and thoughtful idea. This has been done only in a couple of patients, but there are ongoing trials. So what they did in this study is people who had progressive metastatic renal cell carcinoma, I believe they were on their 2nd or 3rd lines of therapy, and they were injected. And so what we're really looking for is that stable disease. And so about 60% of them actually had stable disease, and they had some additional medication given to them afterwards. The problem with this is it has some bone marrow issues, some myelosuppression, right, in 86% of people, and so they need support for some of those things. But girentuximab is not the only molecule. This will get a name at some point, but DPI 4452, they did the exact same thing. They put gallium attached to this. They did a PET scan, and in this middle panel you can see a hot spot. And it shows up very bright in comparison to our conventional PET scans. These SUV maxes are things that we look for uptake. Usually in traditional kidney cancer, it's pretty low, like 5. This shows up as 60. So it makes it easier to see. Another interesting aspect of this is that in this small study, there was identification of 17 lesions that were found that weren't found with conventional imaging. So it might give us a better sense of, like, you know, is NED there or not, or is it a stable disease? So these are some of the intravenous kind of more systemic therapy options. I just want to bring up another topic, not really another topic, but more of a local treatment with some radiation. And this is a paper out of Moffitt where I practice from our interventional radiology department. So what it is deuterium, which is a radioactive substance that's in a microsphere. And this person had multiple liver metastases. Typically, liver metastases are thought to be a more challenging area to treat, and they have, unfortunately, higher rates of progression. But what they did is they drove little microcatheters into there and deposited this deuterium radioembolization. And you can see over the course of time that these were no longer contrast enhancing, meaning they're treated areas. The follow-up in this study was 17 months, and very few of them had really adverse events because it was directed to right to that area. And 16 and 17 had a response to this. We are, as especially, are starting to think about this in the primary kidney tumor setting as well. There's a study going on called the Renegade trial that is very novel and interesting. We'll see what that does in the next couple of years. So there are some antibody-based trials, small molecules, looking at girentuximab, that DPI 4452, and then PSMA studies. And so just because it says prostate-specific membrane antigen doesn't mean it's not in kidney cancer either. So there are lots of opportunities. Nuclear medicine tests right now are a little bit limited in what they can offer, but in the future I think there's going to be a large opportunity to maybe improve on some of the things that we offer patients, and I think theranostics is going to be a really interesting aspect if we can figure out a way to help patients live longer and better, but we need to figure out the better part as well. And then these are my little kidney surgeons that I'm going to go back home to. This is Beth snatching a kidney out of a stuffy, and Zoe's got another one. So this was their indoctrination, I guess, into kidney cancer work. Thank you very much.
Quick question.
Yeah.
I've seen a lot of the Y90 radioembolization of the liver.
Yeah.
The only mess I've had out of G is the liver. Shrunk it, started to grow again. Hopkins, I don't know if you're familiar, in fact, there's only been 4 of us. I've done very well. I don't know if you ever heard a TACE procedure, which is a little different than the radio, where they go on in and it's transorbital chemoembolization. Blew up basically, I put a hole in it, but I've been doing great.
Sure.
Is that a procedure that you've heard about? Because to my knowledge, just like adding the cabo to the Opdivo, I mean, I don't know pretty much anyone else that has had this taste procedure done other than me. So far, it's been successful. It's going on a year. They're thinking a liver resectomy. It's been so good just to play it safe, actually cutting it out now. So I just asked, have you had any experience with the taste procedure?
No, like very limited. I know that they do that
For liver.
for like, yeah, hepatocellular
Liver
carcinoma. I bet you if I had one of the guys from the interventional radiology department that they probably have done that. I don't have any patients of my own who I've sent for that.
It seems I'm an abnormality and everything, but I'm
You know,
doing
sometimes
great.
sometimes that's good, right?
That's
I'm
not the
doing
word
great.
I would use.
Yeah. One last follow-up on this. One of the discussions we've had on forums, so this is why I'm bringing it up. I've seen this a lot. We all get the standard CT scan, our abdomen, our chest. We all get that. That's your standard 3-month scan.
Yeah.
I've seen this brought up. I just want your opinions on it. Of course, when we go in the beginning, they do the brain MRI. They're checking for everything. Then they get your lesions and they give us our therapies. And it's like they get away from looking at the brain. And this is something that's been a hot topic in our forum. So I just wanted your feeling on it. Why do they do that? Because I haven't had a brain scan since my initial diagnosis in late 23, so I'm going on 2 years. So do you have a recommendation on that? I mean, I'm wondering, for all I know, I've got it in my, my legs. I don't know. They don't scan my legs. They just do my abdomen and my chest, and I guess that's the most likely places for it to pop up. But what's your recommendation for, let's almost call it a full body check, because it can go anywhere. They don't seem to focus on that for a lot of us, because I've got the feedback. I'm not the only one.
Sure.
In this case, I'm not the only abnormality. It looks like a lot of our members aren't getting the brain MRIs done annually or biannually. So what would you recommend for RCC stage 4? How often should we go to our oncologist and say, hey, let's take a look at our brain? I'm starting to, think about that.
So that's a great question, and it's a little bit of a challenging one. So what my recommendations would be is like a CT of your thorax, abdomen, and pelvis. And then you talked about brain, but there's also bone imaging, right? So really those things are indicated when somebody starts having some neurologic changes. And so that's typically when we'd get them, or like bony pain, you get a bone scan or a PET scan if there's like, hey, there's pain, this doesn't really make sense.
What you're saying the standard of care in this case is, unless we're symptomatic,
Yeah.
it's not the norm then to get your brain scanned every year or two.
Yeah.
I mean, why wouldn't you be proactive there? Because if you catch it early, isn't there a better chance of treatment?
So from the medical oncology standpoint, I just want to add, I routinely get it once a year to try and catch it early. So.
Yeah.
Yes.
Once a year?
Yes.
Thank you.
Daniel.
Thank you so much.
I have a question. And Daniel, once a year, wink, wink, you have a headache.
Yeah, I know. I'll get it.
Okay. First of all, thank you. Great presentation. And I know you're not a radiologist, but you did show scans. And there's an issue in this group and in our community, and it's a personal one to me. So I'm asking you this more as a doctor than as a radiologist.
Sure, yeah.
It seems there's an increasing amount of radiologists totally missing things. And missing large masses that they should be seeing. And we know they're overworked and we know they're busy. When I see a doctor that I don't have 100% trust in, I get a second opinion. How do I get somebody to look at radiology scans other than my oncologist that I can feel comfortable with that is giving it a second look? Because this is happening more and more. And I know in this audience I can name 5 or 6 people where they have absolutely missed masses they should have caught.
Yeah, it happened in my clinic fairly recently that I saw a lady with a large kidney cancer, and I was scrolling down looking at it with the resident. There was a 10-centimeter tumor in her abdomen and not commented on. So, so there are times where, at least for me, I really like to get imaging at places where I know and trust. And whether that's at like the tertiary care center, at least to have like a baseline so there's something I can compare to. I think it's important that from a surgical perspective at least, and we teach this to like all our trainees, is you need to look at the imaging yourself too. Like, we're not radiologists, but you know, we know the spots that we should be looking for. Are there times where we have missed it? Yes. And the radiologists picked it up? Yes. But I think it's important, and it's if a physician is willing to show you the scan, sit down and show you and scroll through it with yourself, I think that's a good opportunity for you to see what's going on as well.
But is there a way to ask for a second opinion on a radiology? Like,
Yeah.
And I'm not talking
Yeah.
about a 1 millimeter difference that's subjective on a measurement. I'm talking about missing a 10 centimeter lesion in your abdomen.
Yeah, at least at Moffitt, you can, if somebody comes with outside imaging, we can do an outside radiology read, or we pick up the phone and we have somebody give us a wet read of it.
And patients can request that?
I think that would just be totally fine, yeah.
We do the same too. Like if it's an outside imaging, we can get our radiologist to put an official read on it. But same with us. I mean, I always tell patients, if you want something done right, do it yourself. So I always look at the images myself too.
So two things for this group. One, ask your oncologist to read the scans with you and show you the pictures. And then number two is, it is okay to ask for a second opinion. And I'm not talking about outside radiology services. I'll use a hospital. Great hospital in
Sure, yeah.
North Carolina. Radiologist, resident looks at it, attending confirms it. Somebody else, pharma company does a review and finds things that were there that they absolutely missed. So we're not talking about outside going back to inside. We're talking about a really good hospital that are missing things that it's not seen.
Yeah, I mean, I think it's okay if you want to have, like, if there's something and you were like, hey, I'd like a second opinion on imaging. I mean, we were talking about second opinions on treatments of medical oncology, right? And everybody says, yeah, absolutely, or second opinions on surgery. And I definitely, I mean, I've had to have surgery myself, and I got second opinions. And so if you were concerned, if there was like a major concern, I don't think it needs to happen with every single imaging, because then that's going to create a backlog for everybody else in the room. But if there's like something, then I think it's reasonable to look at it, if there's concern.
Good answer. A lot of people don't know that.
I would say one thing, just in fairness to the medical oncologist. I mean, as surgeons, because of what you're doing, it's based on the imaging and the anatomy. It's second nature for us to look at that. For the medical oncologist, they may not have had that experience or the training. So just be cautious. Just because your medical oncologist is like, well, I don't want to look at the images myself. That's not a bad thing necessarily. Just may not be their practice.
Yeah, I totally would agree with that, that surgeons should be looking at your imaging, and medical oncology might not like have some of those same nuances. And they might. Some are really good at it.
Hi, so Sherry's been in the war 14 and a half years now, and going to a lot of good hospitals, Northwestern in Illinois, Cardinal Bernardine Cancer Center, and now she's at MD Anderson. Mm-hmm. But any time they've found a new growth, it's been with a PET scan. The only time they found a new growth was with a PET scan. So we were always like, well, PET scan, maybe once every 6 months. I understand the insurance companies hate it.
Yeah.
You know, I get that totally, but in a case like her, now she's got a papillary 2 type. Mm-hmm. So I know it's a little bit different, so I don't know, does that make a difference, that it's showing up more on a PET scan?
So, I mean, that's hard to say. So part of it is with like the traditional CT scans, they have higher resolution, but they might not have that active cell or those active tumor cells that are really, really small or too small to really make a determination. Those would probably eventually get big enough that it would be resolution for them to do it. So is there...
Would the PET scan show a smaller area that the regular CAT scan or MRI may not pick up?
It should have the same area, because a PET scan has like a CT component to it as well. The CT component is not, the resolution is worse than like a traditional scan. But if it's small and active, then it's something that's concerning, yeah. There's a potential for that.
Thank you again to Dr. Zemp, and now I feel much better whenever I have to sit through hours of traffic to get to UCLA rather than the 18 closer outside imaging places for me. So I think it's a great reminder about second opinions, and also seeking care out that you're comfortable with. And sounds like we maybe need to schedule an AI conversation for the next symposium, because I know that's kind of also of interest. Now I'd like to bring up Lori Bumbaco, who is a dear friend and also part of our JNF community. She is an oncology dietitian at Northwestern Medicine and the host of Talking Nutrition with Lori. And so I hope that you all are, tuning into Lori's amazing content with us at Judy Nicholson Foundation. And she'll be talking about nutrition and kidney cancer. Lori.
Just for the sake of time, we'll get moving. So in private practice, I counsel people all over the country, and I even have international clients. I have someone I'm working with in Italy right now, so I feel really lucky in that I get to pursue my passion. And oncology nutrition is all I've ever wanted to do. It's all I ever will do. The CSO in the alphabet soup after my name, that stands for Board Certified Specialist in Oncology Nutrition. So less than 1% of practicing dietitians have that designation. I'm very proud. Yes. Thank you. I've had that since 2009. And so that requires that every 5 years I have to take my boards, because the information about oncology as well as nutrition is so rapidly evolving, right? Okay, so the topic, you see the title of my presentation, Nutrition and My Kidney Cancer. Now, for the sake of time, we need to keep in mind this is going to be generalized, right? I really have to give you broad information. But ideally, nutrition counseling really should be based on individual patient circumstances, right? You're all unique. And so hopefully if you have not worked with a dietitian, you also will consider that moving forward. So on the menu today, get it? I'm going to start first with the value of nutrition counseling in cancer care, switch towards an overview of the nutrition recommendations, and then wrap with the hot topics in oncology nutrition. That's a fan favorite, so stay tuned. And then I'm going to share some resources along the way. So let me just raise this up so I'm not leaning. All right, so the value of nutrition counseling in oncology care. Why do I exist? Why do I have a position where I do? If you didn't know, cancer and the treatments used really create a physiologic burden, even for someone who is otherwise pretty healthy. So the priority very often when I'm on the front lines is to preserve that and to make sure someone is eating enough so that they can support their body's own physiological processes. If they're doing that, then we might also incorporate some other targeted foods and nutrients that will exert some properties that are anti-cancer and may address some of the hallmarks of cancer, such as inflammation. And then also, I'm well aware that when someone is diagnosed with cancer, there's a high level of anxiety and distress. And what we choose to eat is one of the few things we can control, right? So I really honor and respect that and hope to empower my patients in making those decisions. Okay, so I want to just switch gears and speak quickly about malnutrition. Malnutrition is an independent predictor of outcomes. So regardless of someone's age, stage of their disease, any pre-existing conditions, if someone is malnourished, it is associated with worse outcomes. They will be at risk for greater risk of infection. They will not tolerate treatment as well. They will potentially have interruptions to their treatment, and they'll certainly have some complications from their surgery. Now, according to the research, an estimated 20% of those who are diagnosed with kidney cancer are malnourished at some point during their cancer care, and 20% of those who are diagnosed with cancer will die. Not from their disease, but from something called cancer cachexia. Now, malnutrition and cancer cachexia are two different things, but there is some overlap there. So now you might be wondering, how do I know if I'm malnourished, right? Because we're not talking about simple starvation malnutrition, we're talking about disease-related malnutrition. Well, there was a paper published almost 2 years ago and it found that there are 6 tools that are validated for use in the outpatient oncology setting, and that can determine if someone is malnourished or is at risk for malnutrition. It's important to keep in mind that it is a snapshot of time, right? So if someone is not currently malnourished, it doesn't mean that they won't become malnourished. Okay, so ultimately, working with a dietitian will help you determine, reassess, and determine what is the appropriate intervention. So there's good news. I'm presenting a lot of bad news, right? So there's good news. You have dietitians that can help. So a registered dietitian, according to the evidence, has been shown to minimize the risk for significant weight loss and malnutrition. I had to take a sip, sorry. Promote optimal nutrition intake while managing symptoms and side effects. Utilize diet to support proper kidney function. My favorite, optimize quality of life. And then also too, increasingly I'm finding this in practice, there's a lot of mis and even disinformation that our patients encounter, and caregivers as well. And so much of my time, I would say the majority of my time, is spent clarifying what makes sense for them to believe or not believe and provide them with trustworthy information. So when you meet with a dietitian, I want you to know that each assessment is unique and comprehensive. We don't give cookie cutter advice. That's the problem with Dr. Google, right? And your friends at the salon that might be talking about nutrition. The goal is early and ongoing assessment for appropriate intervention. And what we intervene with will depend on a lot of variables: the treatment modality, the intention of treatment, the presence of high blood pressure, and or the presence of impaired kidney function, which makes every single assessment and intervention unique, right? So no single intervention is the same. And the later nutrition care is implemented, we know the more difficult it will be to modify a patient's nutrition. You're raising your hand or just stretching? Yeah, I'm in the same boat. I know. All right, so I just want to switch gears. What do the experts recommend about nutrition and what to eat following a diagnosis? So dietitians affectionately call a whole food plant-based diet the WFPBD. Maybe you'll take away that from today. And what that means is essentially eating a lot of fruits, vegetables, whole grains, beans, lentils, nuts, seeds. Nothing new, right? But eating a lot less animal foods. So it could be vegan, it could be vegetarian, but does not have to be. You will still reap the same benefits of eating a whole food plant-based diet by incorporating some small amounts of animal foods. Now, it's not just any whole food plant-based diet. We want to emphasize minimally processed foods, and the ones that I pick on the most when I'm working with patients are SSBs, or sugar sweetened beverages, and then processed meat, so things like a hot dog. We know that's not the most nutritious, right? They're all beef. I love you. Now, I will mention, like, there's something to be said about pleasure. Food is pleasure, right? So we can find a balance here. Yeah, I might be your dietitian. No single ingredient contains all the essential nutrients that we need, right? So sometimes I hear some people talk about superfoods. We want to keep in mind that we want to keep in mind a diet pattern. That's what's really going to create the greatest impact in terms of meeting goals and also saturating our body with the nutrients we're looking for. So sometimes it helps to conceptualize what a whole food plant-based diet looks like. So we think about a bowl or a plate. And maybe you can do this for lunch or dinner tonight, maybe. So if half of your plate or your bowl contains fruits and veggies, you're off and running. You're off to a great start. And then divide that plate in half again, and a quarter of the plate for our carbs. So we want some healthy carbs, quality carbs, so our starchy vegetables, and then our whole grains that are high in fiber. And then the remaining quarter of the plate for our protein. And again, we can think about animal proteins as well as plant proteins to saturate the nutrition. We're going to prepare those foods with healthy fats like olive oil, avocado, and then we're going to enhance even further the nutritional content with our herbs and spices and trying to minimize salt, right? So here's what that looks like. So pretty, so appetizing, right? And culturally, there's lots of options, but what you'll notice is that most of the plate has our plant foods, okay? Now let's dive deeper into what is so special about a whole food plant-based diet? I have to start with plant proteins. So the foods that are highest in protein that come from plants are beans, lentils, soy foods, my favorite. So edamame, tempeh, tofu, seeds, and then whole grains. And it is possible to meet all of your protein requirements with just plant foods. That's a misconception. I like to refer to plant proteins as protein plus. So you get protein, but then you also get a lot of other nutrients as well as fiber. I'm going to talk about fiber next. And what's great about plant proteins are that they have been shown to reduce inflammation, reduce the potential renal acid load, and reduce uremic toxins, which all preserve kidney function. So check, check. That's what we're after here. So I have to, every presentation I have to talk about fiber. Are we eating enough fiber? No. It gives me job security. We all need to eat more fiber. So there's some examples on the slide like ground flaxseed. Raspberries are not just a good source of fiber, they're a great source of fiber. So some people welcome that. And then beans. I think the most underrated food we could eat are beans. So lots of anti-cancer mechanisms. I feel like with fiber, there's nothing it can't do. It supports gut health. It aids in blood sugar control as well as our metabolic health. It regulates inflammation, and it helps promote bowel regularity. Now, a special component of fiber, when I hear fiber, I automatically think of prebiotics. Has anyone heard of prebiotics? Some of you, yeah. So in case you missed it, back in July, we did an open forum, and yours truly was on the panel. And it was about probiotics and immunotherapy, right? And how we might be able to manipulate the gut microbiome with specific strains of probiotics in order to enhance the efficacy of immunotherapy. Like, game changer, right? So there's a lot of active research at the moment, so we have to stay tuned to learn more. But in the meantime, it doesn't hurt to use the one single way of manipulating the gut microbiome, and that's through diet, okay? So prebiotics are our friend, and they are considered food for the beneficial microbes that live deep down in our gut. And as I shared, they may enhance efficacy of immunotherapy through the gut microbiome. Really exciting. So onions, garlic, dandelion greens, sunchokes or Jerusalem artichokes, and wheat bran are some choices. If you are like, no thank you to any of them, we're in luck because some food companies are adding them to some functional foods. And a dietitian can help you explore that and figure out ways to incorporate more. Now, the experts at this time, we don't really know how much is appropriate, especially in the setting of immunotherapy treatment with oncology, but experts are advising about 5 grams per day. So we really want to emphasize the foods that you see on the slide here. And a dietitian can make it taste good. That's the other thing we do, I think. All right. One of my favorite aspects of a whole food plant-based diet are phytochemicals. Anyone hear of those? So they are unique compounds that are found only in plant foods, and they are responsible for giving the plant its color, the flavor, and the aroma. And so think of the burnt orange color of turmeric, that's curcumin, the bite, the bitter bite of arugula, and then the smell, the lovely aroma of garlic. Those are all responsible from phytochemicals, and they are actually part of the plant's immune system. And when we ingest phytochemicals, and there's tens of thousands of them, that effect transfers over into our body. Really fun stuff here. So we want to think variety, and that's why you'll hear some dietitians say, eat the rainbow, right? Still exists. So if you're looking for inspiration for a whole food plant-based diet, I'd like to recommend the DASH diet. If you have not heard of it, it stands for the Dietary Approaches to Stop Hypertension. And this is a snapshot. I'm not going to really go too in-depth about it for the sake of time, but the National Heart, Lung, and Blood Institute, as part of the NIH, and actually a dietitian was involved in developing the DASH diet, created this approach. It's a pattern of eating. It's not a specific diet, but it's rather kind of a set of targets. And it's been shown in a relatively short period of time, in 2 weeks, to lower both systolic and diastolic blood pressure. Really effective here. So this is sort of a snapshot of what it looks like. It's plant-based when I look at it. So if you want, their website is amazing. So if you want to just check out just Google DASH diet. That's one thing you can Google. At the same time, with all of these plant foods, it's low in sodium. So less than 1,500 and up to 2,300 milligrams per day. right, moving along. So speaking of sodium, let's talk about salt. So most of the salt that we eat comes from takeout food, highly processed food, not from our kitchen, not what we shake at the table when we're cooking food. So how much do you think the average American consumes in terms of milligrams of sodium per day? 5,000 probably. Yeah, I just gave you the target, 1,500 to 2,300. When we take these surveys, we're asking people how much they eat, and we're getting this result, 3,400. Are people honest when they say what they eat? No, they want to impress whoever they're talking to. So probably this is an underestimate. 5,000 is closer. You can vouch for that personally. Yeah, so we're probably eating double what we should be. So we can, more job security for me. All right, so if we cook at home more often, we're gonna reduce sodium intake right off the bat. And I love the idea of, I'm guilty of not doing this more often in practice, like really looking towards our herbs and spices to really complement flavor, and even infusing some of our oils with them and using different types of oils, because we can really tap into flavor that way without relying on salt. And a little bit of salt goes a long way, right? So we're not gonna avoid it altogether, but just a little bit. So this is another nice little image of sort of examples. Sometimes you'll hear 3/4 of the plate, sometimes you'll hear 2/3 of the plate with mostly plant foods. Just some more ideas for you to kind of explore. All right, the fan favorite. Here we go, hot topics. What do you think I'm gonna talk about? Alcohol, oh man. Jalapenos. We gotta start with the ketogenic diet. Have you heard of the ketogenic diet? Yeah. So there's actually, in clinical setting, there's a handful of different types of ketogenic diets. So there's actually 4. And I'm going to go back to this. So just to clarify, it is very low carbohydrate, there's no question, which is so unfortunate because that's not a whole food plant-based diet. That's the opposite of what the experts are recommending. It's very high in fat, and it's moderate in protein. Because if you're reducing your carbohydrates so low and you eat too much protein, there's something called gluconeogenesis, and you will not become keto adapted. So it has to be moderate protein. Now, what happens when someone becomes keto adapted is that the replacement energy, instead of glucose, it becomes ketones, and those ketones are suitable for function of most of our organs, but it's not suited to meet the demand of a brain tumor. So therein lies the exception in the world of oncology. It looks like gliomas, which are very distinct tumor types, seem to be the one potential metabolic therapy that might be of value. And right now we're looking at it. We don't have any definitive guidance. So on the slide, you see 2 examples of keto recipes. Get ready for this, don't fall out of your chair. All right, so the first one looks healthy. It's like an avocado ice cream. It has 2 small ripe avocados, 8.5 ounces of full-fat coconut milk. That's a lot. 2 tablespoons of MCT oil. And that's for 2 servings, which is probably a tiny little cup. The next is, and so that's 92 grams of fat. Wow, that's a lot. The next is like a chicken and broccoli dish. And so for this dish, the recipe calls for 1/3 cup of heavy cream, 2 tablespoons of butter, 1/2 teaspoon or tablespoon of extra virgin olive oil. Doesn't sound like a lot, but that's for 1 serving. It's a lot. Yeah, geez. Ouch. All right, so here's what I want you to know about the ketogenic diet. A few things, actually. So there is a distinction between a medically induced ketogenic diet, which happens. It's actually a therapeutic approach used in pediatric epilepsy. But pretending that you're going to be keto, following a keto recipe here and there, it's not the same thing, right? So some dietitians, I'll hear them say, don't dabble in keto. If you're going to do keto, go all in, but be appropriately guided, please. It is very challenging to follow, as you can imagine. So a lot of research, actually, they have a hard time keeping people on study or on trial because people don't want to eat this way. They have a very hard time following it. It's not without risk, so there are some relative contraindications, but also we do see the risk for kidney stones, for progressing kidney damage, bone mineral loss, and some common side effects include constipation, keto flu, and fatigue. Most people do not welcome that, right? It doesn't sound like the best idea. And there is no data that suggests it's a benefit for kidney cancer, so I would advise anyone I'm working with who has that diagnosis not to follow it. Okay, moving on, intermittent fasting. So what intermittent fasting, or even fasting itself, what it is depends on who you ask. There's so many different regimens out there, but most involve little to no food within a specified time frame. So it's not like you're waiting a day or two to eat. You're just eating within a shortened window during the day. It has been shown to be effective in improving insulin sensitivity, cardiovascular improvements. It is anti-inflammatory, and it may kind of be sometimes layered on top of someone who's looking to lose weight and just doesn't naturally wake up hungry and eat breakfast. Sometimes I talk about intermittent fasting for them. And the observed anti-cancer effects are attributed to enhanced oxidative stress and DNA damage to cancer cells. So pretty intriguing. But what I want you to know is that it requires consistency. So if you were at dinner last night and you took the gingerbread cookies home and you ate it at 9 o'clock at night like I did, but went back to your fast the next day, you're not gonna get the results you're looking for. There is obviously contraindications as well for someone who has diabetes and might be on insulin or other hypoglycemic prescriptions. The benefits of fasting, even though it sounds so appealing and flashy, I think it's important to point out that we can achieve those same benefits through other measures, right? We might be able to lower your inflammation through other means, for example. And there's no evidence to suggest that intermittent fasting is beneficial in kidney cancer. The last hot topic, protein. Have you heard about it? It's like the opposite of fiber. We're all eating too much protein. And I like to call, there's 3 macronutrients: carbs, fat, protein. Protein seems to be the darling of the macronutrients. Like it can do no wrong, right? We can eat a chocolate cookie that has protein in it, and all of a sudden it's healthy. No, right, thank you. Just testing your knowledge. So I read somewhere like we need to eat our body weight in grams for protein. Is that true? No, it's not true. So experts and myself in practice, we advise about a range. It depends on a lot of variables, about 0.8 to 1.2 grams per kilo. There is a lack of evidence concerning the requirements or range for those who have both chronic kidney disease and kidney cancer. We just don't know yet, so it's really up to the clinician's discretion and judgment. So sometimes the goal may be to minimize malnutrition and prevent muscle loss during treatment with a slightly higher skew for protein. But we do know that lower protein diets, even lower than 0.8, may have multiple benefits in chronic kidney disease. So again, it really just depends on the clinician's judgment. So what I want you to know is that your recommendations for protein really are definitely specific. And we use this, and it might be, again, a snapshot in time, because maybe your kidney function improves or doesn't improve. So we want to reassess that as well. What we recommend will depend on chronic kidney disease, the presence of it or the stage of the disease, the pace of progression, comorbidities, surgical history, age, functional status, malnutrition, the presence of uremic symptoms, side effects of treatment, and the goals of care, of course. Now, just a quick little news flash, our dietary guidelines of Americans are coming out within the next year, and I heard through the grapevine that there's going to be an emphasis on plant proteins. And so hopefully, like other dietitians like me are celebrating this, because it's about time that we start to focus on the value of plant proteins. It seems like they can meet our physiological need while also supporting our health goals. So just to summarize, I know we want to eat lunch. I know the value of food, trust me. So nutrition counseling with a dietitian can improve outcomes. It's tailored to the individual. Malnutrition independently predicts outcomes. Hopefully I raised awareness around that, if anything. And then eating a whole food plant-based diet seems to really have multiple benefits, not only with cancer protection, but also preserving kidney function. And I wanted to leave you with this quote. There's a very popular quote from a Greek physician, but I thought this was better suited to share. So it's far more important to know what person the disease has than what disease the person has. And I think that's so true for what oncologies do in practice. The other famous quote is, "Let food be thy medicine." I like this quote better. soy. Yeah.
You eat a lot of soy. I'm asking about soy. There's rumors that if you eat too much soy, it increases breast cancer and that it can cause other problems, yet tofu and all those things you're saying are good. So
Yeah.
I've always wondered, soy protein powder, that kind of stuff.
Yeah.
What's your recommendation about like that?
So at the end of the day, most dietitians, myself included, are going to recommend food first. So I would recommend whole soy foods over a soy powder or protein supplement. And that goes pretty much across the board for most foods, is that we recommend food first. Sometimes there's exceptions. But specific to breast cancer, what we learned is that there are two different receptors, one on a breast cancer cell and one on the cells in our gut. And I like to describe it as like a lock and key. So the phytoestrogens that are present in soy, we used to be, just to make sure everyone understands we're all on the same page here. So if someone has a breast cancer that is estrogen receptor positive, I could understand we would be worried that eating phytoestrogens that might look like estrogen or act like estrogen, wouldn't we want to avoid them because they're going to potentially fuel that breast cancer? What they found is that the phytoestrogens, let's pretend that's the key, it doesn't fit into the lock on the receptor for the breast cancer cell, but it does fit into the gut receptors. And so because of that, and because of the observational data where we have tens of thousands of women who, following their diagnosis, have lived longer when they consumed whole soy foods. So we're actually at a point where I think we would be remiss if we didn't recommend whole soy foods. But again, one food doesn't make or break a diet. So if someone still has some fear around soy or doesn't like soy, we talk about other ways that they can contribute to their diet, but we don't need to be afraid of it anymore.
So I have a question about these Beyond Burgers and things like that. Where does that fit in your equation? Because everybody says, well, the Beyond, that's better than eating that hamburger. Or I don't know, just your opinion on that would be good.
So great question, quick response. It's higher in sodium and way higher, and similar in terms of protein and saturated fat. They just use coconut oil when they make those products. So sometimes I think the original is best when it's just consumed in sensible amounts rather than the imitation. And we should have learned our lesson with margarine over butter, right? And I'm guilty. I recommended margarine at one point in my career. So I've learned my lesson and I'm never going back. So but again, it depends on the person. If someone is eating a bacon cheeseburger every day for lunch, a Beyond Burger might be a step in the right direction. And we might, right? And we might talk about other ways to sort of gradually make change, because change is not easy, especially when someone's diagnosed and on treatment. So we work with individuals on that. Hopefully that helps. Yeah, great question.
Hi. Hi.
Yeah,
I have
hi.
two. So
Okay.
one is I'll start with the recommendation for the protein. Is that the same recommendation if you have one kidney?
So I'll share what I do in practice is I look at GFR. And so once it's at 30 or less, that's when I start to, it depends on other variables, but I start to I use GFR as my indicator, and if it's at 30 or less, then I might restrict protein. So we just dive deeper into what it is that they're eating now and what else is happening circumstantially, and then emphasize plant proteins for that individual as well. Yeah.
Question two was the one that everybody, the sugar feeds
Yes.
cancer. So that question.
Yeah, great question. So we don't have that discovery of sugar fueling cancer was made 100 years ago. So I have to believe that since that time we've learned more. And so this may have given rise to my profession, because I think that when we've tried to manipulate a cancer cell through a metabolic diet, it's failed. We have no solutions yet. So it seems like it's more complicated than that, and diet isn't going to be enough to do it. Sometimes what I do work with individuals is we talk about insulin, because high levels of insulin in the body, because someone has maybe diabetes or an insulin resistance, that's conducive to cancer growth, right? Because insulin's a growth hormone. So we talk about lifestyle and helping to modulate insulin levels, and that goes far beyond just cutting out sugar and being afraid to eat sugar, right? Hopefully that helps too. Yeah, that's a great question.
I had a question about the impact of cancer drugs on stomach. You know, my father spoke to having trouble over his treatment. Just trying to understand kind of, I mean, those plates of food looked really beautiful, but when you wake up in the morning and you've been up for a large portion, like just trying to understand like what that looks like, because you know, I get on my dad sometimes for all the bagels he eats, but he, you know, but he speaks to the need for bland food just to get something in the system. So I just wanted to see if you could speak
Absolutely. I think that, you know, what I shared is like I'm on the front line, so I'm part of the interdisciplinary team, and we really max out medical interventions so that someone feels comfortable, because that's a quality of life issue, right? And then we talk about ways to maybe sneak some of these foods into well-digestible types of choices. So smoothies are sometimes my patients' best friends, because you can really make a simple smoothie, taste good, but deliver some good nutrition that you otherwise can't tolerate. And it's intentional, like we may add a banana to the smoothie or oats because that's easier to digest, but then we sneak in some baby spinach. Or soups, which are the savory cousin to a sweet smoothie. And soups can be blended, and I have a lot of success that way too, like a blended bean soup with some other plant foods that could be well tolerated. So sometimes it's just the mechanical manipulation of the food. Yeah, hopefully that helps. Yeah.
Could you comment, please, on grilling foods and also alcohol?
I knew alcohol was going to find its way. Are we doing okay on time? I guess we're going to keep going, yeah. Okay, so great question. So so thank you for bringing up grilled foods. We talk about sensible grilling as well. We don't want to eat anything burned, right? That probably doesn't make sense. And probably not smoked foods. So that's the processed meat, right? If we eat burnt foods, this potentially creates some carcinogenic compounds. Now that we know is linked with the risk for colorectal cancer. And probably again, it lies within the mechanism in that the charring is damaging our digestive system, right? So we don't know about kidney cancer just yet. But if someone is, in my practice, if someone is enjoying a lot of burnt food, we talk about sensible ways of grilling. And it's amazing how a marinade and flipping often and trimming off the char or trimming off the fat which creates the char, that can significantly reduce the carcinogenic creation of the compounds that are carcinogenic. Alcohol, oh boy, it's like a loaded question. I always lean on my oncologist for that one. I'm like, you tell him, I don't want to tell him. I mean, I think it's all context. I think, you know, there's a distinction between a glass of wine with good company that's relaxing, you know, and it's quality of life. So again, I think we don't see a link with kidney cancer, believe it or not. It's with our digestive cancers, like head and neck, esophageal, gastric, colorectal, our breast cancer. We think that the mechanisms, they don't really know. They do know that alcohol metabolizes into a carcinogen. It's called acetaldehyde. We do know that it's a solvent. So if you have other carcinogens in your environment, like tobacco, smoking, you might have, that may like potentially exacerbate how damaging those carcinogens are. If someone overconsumes alcohol, they probably live a lifestyle that isn't otherwise really healthy. And they once thought that it potentially had to do with folate, which is a B vitamin that's responsible for repairing DNA damage, and that overconsumption of alcohol may cause a folate deficiency. So they're not really sure, and alcohol consumption raises estrogen levels. So they're not really sure what it is. So sensible consumption is a serving per day for women, and you can't save up for the weekends. And 2 for men, because men metabolize alcohol differently. It's not because they're bigger. They just metabolize it differently, which is wild to me. Lucky. Lucky devils. But I think, again, I think it's context. And sometimes I talk about priorities, and maybe there's bigger priorities for somebody than the alcohol. Or maybe they're doing everything else on the checklist that I've given them, and alcohol is the next thing to address. Hopefully that helps, yeah. Okay, thank you. Thank you. I'm going to just take care of this.
We're going to go ahead and get back to the schedule so we can get you guys out there to explore Colonial Williamsburg later today. But I'd like to start off with Kathy Russell. She's going to be sharing her caregiving story about she and her husband, Tom. So, Kathy, thank you.
Hi, everybody. Woo-hoo! Let's hear it for the caregivers. So, hi. My name is Kathy Russell. I feel like I'm at an AA meeting. Yeah. So, let's see. How do we get this to go? That. So, I'm the caregiver for my husband, Tom. And, okay, get it there. Our kidney cancer story started in March 22. Life was moving on at a normal pace. We were working, taking care of our family, our home, going to concerts, which is our thing, sporting events, planning vacations, doing all the fun stuff. All the usual things. If you can't tell from the pictures, Tom loves to have fun. I'm sorry, I have to have my notes just like Joel did last night because I'm getting older. In March 29th of 2022, everything that we knew changed. One evening, Tom said he thought he needed to see the doctor because he felt like he was going to fall to the left. And he was crashing into things at work. He would be taking a cart around and crash into a rack of, he worked for Granger, so he'd crash into a rack of supplies. So I called and made an appointment. We were both thinking, yeah, maybe he has vertigo, an inner infection. And we really weren't concerned, you know, it's just something. The appointment with our primary care doctor was about a week out, but the next day he said, I think we need to make it earlier. He just wasn't feeling great. So I made an appointment, and this was with a new doctor because our primary care doctor wasn't available that day. And he asked me to drive him to the appointment, which was only, 5 minutes away, because he felt that his depth perception was a little bit off and was feeling a little wonky. So the new doctor was really nice. She did a normal exam, and when she looked in Tom's eyes, that's when things got serious. She said, you need to go to the emergency room. You need to go now. So off we went to the emergency room, and she had called ahead and told them that we were on our way. In March of 22, COVID was still a thing, so the ER was full of people. Initially, Tom was in a room, but eventually he got bumped out into the hallway of the emergency department. They did an MRI of the brain, and bam, the tsunami had hit, and our lives changed in the blink of an eye. I'm sure the warriors and caregivers out here can relate to this statement. Our lives are now measured based on the date that you first find out that you have cancer. So March 29th, 2022 became our new starting point. So while he was on that gurney in the hallway, the very nice nurse practitioner came up to him and told him that you have a brain tumor on the right side of your brain, and that cancer is very likely. We were then told they were going to do a CAT scan to see if there were any other tumors. How do you react to that when you're sitting in the hallway? The CAT scan showed a very large tumor on his right kidney, lesions in his lung, liver, spine, and an eventual biopsy showed lymph node involvement. This time, a resident told us, while we were still sitting in the hallway on a gurney, that he had stage 4 cancer, but they didn't know the origin yet, but he thought because of the size of the tumor that it was kidney cancer. I guess it's good that we were both in such a state of disbelief that we didn't scream or cry out there in that hallway where every other patient and visitor could see our grief. My inclination in most things is, okay, now what? What are our next steps? Tom was admitted to the hospital, and by the next morning, he was being seen by the radiation oncologist. I went home after the meeting with the radiation oncologist and had to pull over twice on my 20-minute ride home because I couldn't see the road through my tears. Of course, you know, I had been looking at Dr. Google and felt like my husband had just been given a death sentence. When our son got home from work, I sat him down and told him that Dad had cancer and that he probably wouldn't be here next year. Our son, in his infinite wisdom, said, don't worry, Mom, Dad can get through this. I guess my thought then was ignorance is bliss, because he really just didn't know. Our world and all the plans that we had for the future had just been turned upside down. I slept on high alert for a very long time. I would wake up most nights, and actually about every hour initially when he was home, just to make sure Tom was still breathing. If I started tossing and turning, I'd go downstairs and try to sleep on the couch so that I didn't wake him up. During this time, I took on almost total responsibility for the running of our home. I became a chauffeur, and I tried my best to not show how afraid I was of losing him. Just a little bit about me. I have a bachelor's degree in nutrition, so how ironic is it that you have a dietitian before lunch and then you have a dietitian after lunch, right? Okay. But my degree, I have a bachelor's in nutrition and dietetics and spent most of my working life as a registered dietitian. I worked for about 10 years in a community hospital where I worked on the med-surg and oncology units all over the place. I helped write prescriptions for tube feedings and TPN. I was skilled in working with patients that had swallowing difficulties and GI distress. Being on the overweight side, I had a hard time understanding how hard it was for some of my patients to gain weight, because it's never been an issue for me. Never. But I would work with them to come up with nutrient-dense, small snack ideas. I then went to work for one of our state psychiatric hospitals, where I provided medical nutrition therapy for some of the state's most chronic mentally ill patients. Through this time, I went back to school for my master's degree in business, specifically healthcare administration. And currently, I'm working as the CFO, COO, which are terms used in the real world, but when you work in the state administration, I am now called the administrative officer. I've worked there for 36 years now. But the administrative officer, you get all of the work of the CFO and COO, but none of the glory and hardly any of the money, because it's a state facility. Taking care of Tom is not my first caregiving experience. Our son is, and you can't see the picture too good, but he's got a really good gash over his eye. We adopted, and he suffered a traumatic brain injury during birth. So he has some cognitive deficits. They're not much. I mean, if he's very high functioning, but if you spend a little bit of time with him, you know that there's a little bit of neurodivergency. He has his own ways. He's right on top of it, though. He doesn't require much in the way of physical care, but he still needs quite a lot of guidance and mom-level support. Over the years, my mom had 3 primary cancers. She had breast cancer, colon cancer, and thymus cancer. She had chemo for the breast cancer, a hemicolectomy, and chemo for the colon cancer. And my dad was her primary caregiver, but toward the end of her life, I then became a nurse, and a homemade. Now let me tell you, I went into nutrition because I cannot handle what comes out of people. I would much rather deal with what goes in them than what comes out, let me tell you. Because of the hemicolectomy, my mom had some frequent bowel accidents and issues with that. And cleaning that up was unpleasant at best. I had to learn how to pack wounds and change dressings. Sometimes I ended up gagging, and I felt so awful for doing that. She apologized to me saying she had the same problems, I shouldn't feel bad, but boy did I feel bad. When she died in February of 2020, just before COVID, I became the primary caregiver to my dad. For the next few years, mine and Tom's biggest worry was how to care for my independent but failing almost 90-year-old father. By the way, curmudgeon of a father. Our biggest concern was his ailing health and how in the world were we going to broach the idea that he might need more care than he was willing to let us provide. We lost him last September. And thankfully, he was independent to the very end, and then went in the hospital and was kind enough to die in the hospital, so I didn't have to worry that when I went over, I would go over every day at lunchtime from work because he lived 5 minutes from where I worked, and I was always worried, what am I going to walk into? Is he going to be on the floor? Is he going to be dead? There were some interesting things. So then we begin moving into cancer treatment. For Tom, the first thing they addressed, of course, was the brain tumor. The morning after being told that he had cancer, even before they knew what kind of cancer, the radiation oncologist was in to see Tom. He was measured for the mass, and he started radiation within a couple of weeks, and it was really rather amazing how fast that happened. We still see that radiation oncologist, and it's now spread out to MRIs being about every 4 to 5 months instead of every 3 months. But we had to have something to focus on that was positive with this, and he's a great doctor, but he always has interesting socks on, so the question becomes, what kind of socks is Dr. C going to have on today? You all know that beyond the cancer, the treatments can be brutal. Tom has had his share of problems. His first line was Nevo and Cabo. The first infusion of Nevo sent him to the emergency room. We live about 5 minutes from where he was getting the infusions, and he felt fine while he was there. We got home. Again, 5 minutes. He put away the trash cans and went in to sit down, and by the time I got the mail and got inside, he was shaking so hard that I was afraid that the big, heavy, reclining chair that he was sitting in, I was afraid it was going to break because he was shaking so hard. Called the center. He had spiked a fever of over 103, and he couldn't stop shaking. I called the infusion center, and they told me to take him to the ER. On the way there, about a 20-minute drive, the fever broke. He felt fine, but we still went to the ER. They did a ton of lab work, blood cultures. All of the results came back normal. They chalked it up to a reaction to the immunotherapy. But after that, I decided he could not go to the infusions by himself anymore, or ever. I didn't want him to have another bad reaction without me being there. As it turned out, the Nevo caused acute liver failure, and the Cabo caused a kidney injury. So you have kidney injury on top of kidney cancer. Tom being Tom, he showed his support for kidney cancer by turning a lovely shade of orange. He was, I mean, think about an alcoholic he was orange. His urine was orange. Everything was orange about him, kind of like a Oompa Loompa. So it was another trip to the emergency room, and it was on this trip that I almost fired his oncologist. Maybe you should think about quality of life versus quantity of life. Now, let me tell you, we're only 3 months into this journey. Neither one of us was ready to think about the fact that he may not be here. 90-degree weather and cutting the grass as a caregiver is a great way to cry without letting anyone know you're having a meltdown, because I was doing that. Thankfully, this was the attending oncologist, and Tom was actually, in real truth, being treated by a wonderful oncology fellow. And when I shared with her what the attending said, her response was, "Oh, no, 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 no. There are still so many options for treatment. This version didn't work, so we'll try something else." Thankfully, she did. So the Nevo and the Cabo were stopped, and he was put back on very high doses of steroids to get his liver and kidney function back into normal ranges. Of course, while he was on those, he grew another tumor in his brain, so more radiation. After the liver failure subsided and the steroids ended again, he started on Pembro and the Pembro and Lenvima regimen. During his first infusion of Pembro, he had some pretty severe back spasms. He was just going to try to walk them off and stretch through them, but I called the nurse. It seems that this was a reaction to the Pembro, so all future infusions then included pre-medication with Benadryl, and the infusion rate was cut in half, so instead of giving over half an hour, they would give it over an hour. It seemed to work much better, but I still went to all of his appointments. Immunotherapy is a great tool in the kidney cancer toolbox, but there are drawbacks. Tom and I experienced quite a few of these, and I include me in this because I'm there for all of it. The Pembro and Lenvima were working, and Tom's cancer was moving into a state of stability. But we moved into an ER visit truly, I think this was the first time I was afraid that I was going to lose Tom. He had lost about 30 to 40 pounds in a matter of a few weeks. He was so weak that I had to lift his legs for him to turn over in bed. "Kathy, this towel is too heavy. Can you get me a lighter towel?" All he wanted to do was sleep. Eat, forget about it. He didn't want anything to eat. I took him to the emergency room at about 3 o'clock one morning when he was unable to walk to the bathroom. I know the oncologists are aware, and many of the warriors and caregivers are aware, but there are emergency room doctors that don't know immunotherapy can cause adrenal insufficiency. I had been reading about this in our Facebook group. Thank you, Joel, for this group. So I brought it up to the emergency room doctor. In her most tolerant voice, she told me that adrenal insufficiency is a chronic condition. We only treat emergent conditions in the emergency room. I guess then I turned into Mama Bear, and I informed her that I guess if his heart stops, it becomes an emergent situation, right? I was a little hot around the collar, needless to say, and I politely but firmly demanded that they put in a consultation request for endocrinology. The next morning, we were told that he had classic symptoms of adrenal insufficiency by the endocrinologist. One thing that I have found throughout this roller coaster of a journey is that medicine tends to be a bunch of silos. Each discipline is very good and excellent at what they do. They know the meds to prescribe, they know the potential side effects, they know a little about how to treat those side effects, but they know this for their area. The ER doctor had very little knowledge about the side effects of immunotherapy. She was arrogant in not listening to someone who had by this time been helping to care for her husband for over 2 years. Someone that might actually have something of value to offer. To the doctors out there, please think about journal clubs or lunch and learns with those doctors that might be seeing your patients outside of the cancer suite. When new treatments are being used, provide education to the primary care doctors, the hospitalists, the emergency room doctors. Don't keep it all in a silo. Since this visit to the ER and hospitalization, we haven't had to go back, but that doesn't mean it's been smooth sailing. Tom developed immunotherapy colitis, which is another wonderfully fun thing. He was afraid to go anywhere, including the backyard, because he was afraid he wouldn't make it to the bathroom in time. There were many times he didn't quite make it, and here I was again, gagging my way through helping my husband. He would apologize, so then I would ask him, being a sarcastic person that I am, if he was doing it on purpose. If not, there's no need for any apology, except that I'm sorry my body reacts like this. We got through this, and after 2 years of the Pembro, in December of 2024, his treatment of the immunotherapy was ended, and the colitis issues have substantially subsided. When we first started this journey, the doctor was like, well, there's 2 lines of treatment. There's palliative or curative. I also want to add my own term, so there was the theragnostics. I have controlative. You have palliative, you have curative, and then you have controlative, and that's where Tom is. He's on the controlative treatment. We're controlling his cancer. It's not growing, it's stable. Yeah, right? I'll say, having worked in hospitals for over 40 years, and many of them working with patients dealing with a variety of cancers, I always thought and felt like I knew what they were going through, and let me tell you, I was so wrong, because I had no clue. Even after 3 years, I still don't know what Tom is going through. I know what I feel. After 39 years of being married and 44 years together, I can tell when he isn't feeling good, either by the tone of his, I'm fine. Really, you don't sound fine. What are you really feeling? Because I am pushy about like that. Is he dehydrated? Is he sick? Is he tired? Is he having pain somewhere? These are all questions that I don't know unless he tells me. I know he gets tired of me pushing for answers to those questions, but I can't help him if he doesn't tell me what's going on. I understand that everybody doesn't have the same relationship as me and Tom, and that not everyone is in the frame of mind to be as involved as I am in helping to take care of him. But the warriors, you need to share with your caregivers as best you can what and how you're feeling. Most of us want to help in any way we can, and we can't always fix it, but we're really stuck if you don't really let us know what's going on with you. If we don't know, we can't help. As you might have figured out, I can be kind of pushy, and I have to remind myself that Tom still needs to have his independence, to know that he's contributing to our home, our family, and our marriage. I have to very consciously tell myself to reframe how I respond to things. I try not to say, I can do that, you go sit down. I'm asking him more often to run down to the basement to get something that we may need for the recipe I'm making for dinner. I don't tell him to leave the housework or laundry for me to do when I get home. I don't have him save the grass cutting for our son. If he wants to do something, I'm going to let him do it. But I gently remind him to hydrate and take breaks. He doesn't have to be a superhero. A few weeks ago, we went out for breakfast, and he was really discouraged that day because he wasn't feeling great, and that he had worked in the backyard the day before, and it had taken it out of him. I had to remind him, 1, he has cancer, and not just cancer, but stage 4 cancer. 2, he's on medications that cause pain and fatigue. And 3, he's closer to 70 than he is to 40. And 4, even with cancer and being 10 years older than our neighbors, he still runs circles around them. They spend a lot of time on their couch watching Netflix. So, and then they complain they don't have any energy, right? So one ray of sunshine is that I work with the most wonderful people. Can you tell this is work? My boss made sure that I had a VPN and intermittent FMLA so I could take whatever time I needed to be there for Tom, and I'm able to work from home anytime I need to. We recently merged my adult psychiatric hospital with the Children's Center for Psychiatric Care, so we dress up in our Halloween costumes, and that's my admin and my boss. So we have a lot of fun with that. But my coworkers and teams have had my back through all of this. They make sure that I take a break when I need it. They keep people out of my office when they see me showing stress. They plan girls' nights out so I can relax and just be one of the girls. They pray for Tom and me and have enlisted a very wide range of people praying for us. They have let me cry, complain, vent when I need it, and have provided encouragement and optimism when I needed that. They make sure I leave on time to go get a massage or to get the sparkles removed from my hair. Tom's not here this weekend, even though he really wanted to meet you all. The day I was registering for this weekend, he received an email inviting him to a golf outing that he had been going to almost yearly before his cancer diagnosis. This is an outing, it's something he looks forward to every year. And we decided to weigh out the weekend, a 10-hour car drive for a wonderful dinner and meeting all great people all day in a conference room, and a 10-hour car drive back home to 3 days of golf and laughter and having fun. It really wasn't a hard decision. It was not hard for me. It was very hard for him because he really wanted to be here. But he did go. I had to give up control and let him go without me. He's sharing a room with his brother, so that's helpful. And I know at least someone will be there if he has some problems. And his brother also has adrenal insufficiency because he had liver cancer. So fun things, and treated with Pembro. So Tom and I have started doing things on our bucket list. 28 years ago, we were a week away from putting a deposit down for an Alaskan cruise. It was during this week that we found out we had been chosen to become the adoptive parents to our son that was going to be born the month before the cruise. Guess what? We didn't go on that cruise. It took us 28 years, but we did go on that cruise last August. We went with our very best friends and took our son with us. Tom was still having some GI problems, but overall was doing well enough, so we were able to have a great time and see a part of the country that we had wanted to see for years. If he was tired, he had a place to rest, and it was always his choice whether he went on an excursion or not. One thing I have felt a lot of guilt about through all of this is that I still work full-time. We're in the process of having a new hospital built, and I told my boss that I would stay until we got settled into the new building around January of 27, with the big unless. If Tom's health takes a turn for the worse, I'm gone tomorrow. But life has a way of changing your plans. In July this year, one of my coworkers who was healthy had a heart attack, and she died. And that hit me really hard. And Tom and I spent quite a bit of time talking about my feelings. And one thing he told me was, Kathy, I don't want you to retire to watch me die. I want you to retire while I'm feeling good and we can go and have fun. So plan one was I'm going to retire. I was going to get us through our triennial Joint Commission survey. So for anybody that works in healthcare, Joint Commission is a big thing, and if you don't have it, accreditation from Joint Commission, you don't get any money from CMS, Medicare, and Medicaid. But then I decided I might need to reevaluate my plan, get us through Joint Commission, and retire in January. Well, that husband of mine, he changed my mind again. He made, it's like, let's change it again, because on Thursday before coming here, he had his oncology appointment after his after his scans, and the doctor's like, "You are amazing. You're doing wonderful," and said he was Ned without saying he was Ned, because there's still a tumor on the kidney, but we don't know, is it alive or dead? So again, we might be looking at that PET scan to see. I'm thrilled. He's like, "So since I'm doing so well and I'm so healthy, maybe you want to change your retirement plan." So it's like, does he really want me to retire? The original goal was that I was going to retire before him, and now he's been retired for 3 years, and here I am still working. Like crazy, by the way. But anyway, we are still planning trips, and we'll be going to Las Vegas this October with those same friends that we went to Alaska with for a NASCAR race. Sightseeing and some people watching, because I understand there's some interesting people in Las Vegas. So we're planning for next year, though we will still go to Las Vegas again. We will be spending time taking short trips where we can easily drive. Tom's sister has given us a standing invitation to join her and her family in Florida in February. We'll continue to go to concerts as much as we can. We're making plans to go places and do things we've put off for years. I am not extraordinary. I do what so many other caregivers do. I do less than some and more than others. We love our warriors and want them around for many years to come. I told Tom there is no early out for good behavior. From a Willie Nelson song, this is not something you get over, it's something you get through. And that is so true. Our life, we have to get through every day. And it could be arthritis, it could be, a bum knee, a fall, it could be anything. And we all have to get through those things. Cancer is just another one of those things we can get through. And hopefully, we're all going to be here again next year. Thank you.
Thank you again so much, Kathy. And I would have chosen the golf trip too, even though you all are wonderful. So I don't blame him. Maybe you can bring home some JNF golf tees to him. I'd now like to introduce another wonderful part of our JNF team, Jayla Barnes. She is a palliative care nurse practitioner with Baptist Health. She's also the host of JNF's The Art of Caregiving. And if you are not attending her monthly forums online, you're missing out. So please, take a moment to sign up for our next one. And she will be talking about how to take care of caregivers. Jayla.
All right, so I don't have slides for this presentation because, much like our support group, I like to see you and talk to you, both patients and caregivers alike. So one, I'm so glad to come after you, Kathy, because you did such a wonderful job representing the caregivers, but it also, something you said switched just a little of my intro, and that was when you talked about the tsunami, the beginning of the C word. When you first hear that you or your loved one has cancer, that is jarring in and of itself. And there's a flood of information and questions that come to mind. And so that tsunami analogy is great in that it's so overwhelming. And as a provider and a clinician, we walk this journey with our patients and families. She mentioned I'm a palliative trained provider as well, so I'm family medicine, palliative care. I've even worked with our hospice team. We have 15 hospitals in my local area, and we have teams at each and every one of them. My early career was in trauma. I'm a glutton for punishment, and I absolutely loved it. It taught me the beauty of life. It's when you have those tough saves, and it's, oh, we did it. But then I would also encounter really complex medical cases, patients, families, and really deep conversations because there were a lot of decisions that needed to be made. No decision was ever a silo or a single decision because it had so many things that came along with a yes or a no. Do we go? Do we stay? And so one of the things that I've continued to say over the years is we don't drown because of the water that's around us. We drown because of the water that gets in us. And that overwhelming, if you think of the massive oceans that we have out here, if you can imagine one person just being a little dot trying to swim and navigate that, some will tread water, some have swam the English Channel. I mean, you have people, can you imagine what that training and regimen looks like to train for such a feat? These marathon swimmers, they talk to experts, they talk to dietitians, they work out, they do all these things to plan for this big swim. They have to plan for sharks. They have to take into account the sun. They even have to grease up and prepare for jellyfish stings. But yet they still do it, and they keep trying, and they keep trying, and then they're finally successful. It makes me think of, and this is where the caregivers come into this, it makes me think of one scenario that I heard, and again, this is just me planting this seed, not planned, so some of the details of it might be a little off, but you'll get the gist of it. Florence Chadwick, I had to Google her name quickly because I couldn't remember it, but Florence Chadwick was a lady who swam, she was a marathon swimmer. And she had a team that worked with her. She had a team of people that trained and followed her at a certain distance to make sure she's safe and to make sure she's cared for. And they continued to cheer her on. But after several attempts, she never made it to the other side. She'd have to stop for one reason or another. Then one time, her cheering team was yelling something at her, and of course, she's trying to figure out what they're saying and became discouraged. It was a really foggy day. And what they were telling her to keep going, but they could see she was tiring out. And they were telling her to keep going, but she couldn't understand what they were saying. So finally she gave up, waved them down. They got her in the boat and they said, we could tell you were tiring out, but we could see the shore. But because of the fog, she could not. And when she got in the boat, they said, you were a mile from accomplishing this feat. And this is where you are as caregivers. You are on your loved one's toughest day. You're the person in that boat encouraging them to keep going, keep going. The fog is out there. We plan for the jellyfish and all that stuff that people tend to do when we have to deal with something tough. We've talked to the specialists. We've talked to the nutritionists. We've kind of figured out what we're going to do day by day. But those days when it gets the toughest and you feel like, gosh, I can't take another hit, and your team is screaming, keep going, that's what caregivers are. You're the ones that are there to keep your loved one encouraged, whether it's a husband, wife, parent, child, sibling, or really just a good friend. I loved watching you guys last night at the Celebration of Life. The reason being, as certain things were said and some of the casual laughs were shared, I'd see little touches or little smiles and eye contact, shoulder rubs and grabs. It's that personal touch that I could see happening around the room. And part of what's cool about that is this. You all don't know how far that takes you. Think about the newborn baby centers. They have volunteers come in just to do skin-to-skin contact. Why? Because we communicate with each other with more than just our words. It's our action. It's our touch. It's our showing up. And so after doing that time and time again, how then do you, the caregiver, how do you recharge? I say all the time, is the cup half full or half empty? And people get really stumped by that question. And I say, no, you have to ask yourself that all the time because there's always a right answer and it may change. If I'm pouring into a cup and I stop, that's half full. If I'm pouring out of a cup and I stop, that's half empty. If I let that cup empty completely, I have nothing else to give anybody else, much less myself. And so this is where it's important that you refuel, you recharge, you do the work that is also going to give you a chance to be full or filled again. So that means, and Kathy hit on a few of those things, it means going out to lunch with friends. It may mean journaling. It may mean taking pictures. It may mean art and drawing. It may mean discovering a new outlet or a new way for you to be able to be one with yourself that requires you to not keep up with the schedule. Not another doctor's appointment today. 5 minutes of meditation. It may mean just stepping away for a minute to say, how do I feel today and where am I right now? Because you get so busy being a caregiver that you forget to care here too. And you've got to make sure you do that. So there's a couple of things that I think it's important to know, some statistics that come to mind. I didn't prepare a slide with this piece, but I think you'll resonate with it. And it may even be an aha moment for some, or for many of you. We generally know that the female, whether it's a mother, sister, wife, is usually by nature a nurturer, right? And 70% or so of caregivers are female, are women. But this other 30% are the men. And oftentimes we have role reversals or things that we struggle with because it's what we've become used to. And so we have to redefine our purpose, our role, our assignments. Kathy mentioned having the opportunity to cry during cutting the grass. Oh, I can't even, right? But those are times when it's like, you know what? I'd rather be doing anything right now than dealing with what is in front of me. And sometimes those things can feel so unsurmountable. And you need those cry moments, but you also need the laughs and things. I enjoyed the roast last night. Where's Joel? You got, that was a good one. But that was just a little snippet or a little snapshot of sometimes just not only taking the time to laugh with others, but sometimes even laugh at ourselves, right? And so when we look at that, so some of the statistics that will be probably surprising to you is this. In America, caregivers, unpaid caregivers, I'm not talking physicians, nurses, people who do this for a living, but unpaid caregivers, you who are sitting right next to your loved one, your patient, one of the providers, but unpaid caregivers account for over $470 billion a year. $1 billion. So what would that look like if we had to include that or build that into an already failing health structure? What would that look like if you didn't have a loved one or a family, a friend, a member, somebody who could help care for you during these tough times and partner with you to get you the love and the care and the advocacy that you need to be able to challenge and walk through each day? So as the caregiver, it's important that you realize you're pretty awesome. You play a huge role in the success of not only the loved one and the caregivers that are sitting here in this room, but just in the whole shift of our nation, just I'll say our nation, but America. That's just, when you look at other countries, their statistics were fairly similar, but just for this instance, just giving you an idea. I said, well, how does that compare when you look at other industries? And it was like, well, Walmart is a $460 million-ish company. So if you look at that, when you're talking caregivers, unpaid caregivers, outrank that, like just such a huge entity like that. It shows some of the tech companies, Apple and IBM, some of those companies combined, still just from an economic standpoint, don't have that kind of an impact. And so as patients, this forum is for you. It's about what, you need to know and being informed and making sure your questions are answered. Some of what you hear is scary. It's hard to talk about sometimes. It's hard to think about or even fathom. But I love one thing too about Kathy's story, and we've talked before on the forum, is I knew the punchline at the end. I definitely knew that Tom was on his boys trip this weekend, which we're all super excited about, because as I watched some of your faces when she talked about the beginning of that story, gosh, that was a lot to hear and a lot to even think. And some of you may have even thought, where is this going? But it's a true success story in that cancer, period, is scary. RCC, super scary, because like she mentioned, no signs, no symptoms. And research is so important so that we can get the message and the information out there. But then that's where you as caregivers, where your role then becomes so important. She also hit on a couple of other good things that I mentally had some notes about, and that was this. You said, how many years married? 40? Oh, well, together. 39 married, but 44 together? Do you think her husband could look at her face and not know what she's thinking or feeling? Can she get away? Right? And she said the same thing, that he would say, oh, I'm fine, but she knew just by the tone of how he said that. So I bring that out to say this. It's oftentimes, I've been with patients, families, caregivers, depending on the roles, but gosh, I can tell you, they know whether you're truly giving them a real answer or not. And sometimes that guarded nature puts both of you at this little, can make some situations more uncomfortable and hard to talk about. And not every conversation has to be hit head on day one. Part of what I encourage in the group is when you feel that there's an underlying conversation that needs to happen, we're both kind of avoiding it. One of the things that I encourage caregivers and patients to do, we talk about having receptacles. Some of you will nod and you remember this. We talk about having receptacles in the home, maybe with each other's names on it. And again, this could be husband, wife, parent, child, sibling, family, with little note cards. And you can write a question or a thought on one side of it. You drop it in your loved one's receptacle, in their little bin or their box. And then you may have a certain night that you all decide to sit and pull notes and say, all right, let's talk about these things. Or you may just decide to go from time to time, look at what's in your bin, read it, write your answer on the other side, put it back in the other person's bin. The reason I recommend and encourage things like that is because it opens communication up. One of the things that you as a patient, you didn't ask for this, right? Cancer decided to join your life at this point in your life. It's not something you planned for, and neither did your caregiver. But one thing that they did do is commit to be here with you, to walk this journey with you. And that's going to look different every day, sometimes every minute of every day. And it's okay to have changing feelings and emotions and even thoughts about what's next. But also it's important to plan what's next. I love the cruise. I love the boys golfing trip. And I said the boys golfing trip, we were laughing about that earlier. But many of you have other things too. And some people get scared when they hear that word bucket list. It sounds so final? No. You keep adding stuff to that list. I heard grandbabies are coming. I heard weddings are being planned. There's always things going on. But if you really do look at what the challenges are and address those and talk them through, you actually will, it actually does give you a sense of completion with certain tasks that you do have control over, controllative, right? The controllative phase. What things can we control? And so as caregivers, when you're talking about how to care for the caregiver, patients, those of you that are here, but also clinicians and providers, I want to make sure that we remember to check in, what they say, check in on your strong friends. How are they doing? What questions do they have? But then caregivers, I'm going to challenge you with stepping away. Take the time for self-care. I know I've heard, and I think, Kathy, I'm just going to pick on you because you were right before me, but I heard, but it was key and so spot on. You hear the word about guilt. Well, I can walk away from some of this and he can't, she can't, they can't. And it's not walking away from it forever. It is called refueling, recharging, refilling your cup. Because how can you continue to pour out and care for them if you don't take care of you? And who's going to do it if something happens, if you go and go and go and go and go till you burn out? Then who's going to take care of you and them? It's so important to remember that we all are here because we want to improve and advocate for one another, caregivers, family members, patients, clinicians. We would not be the same in how we deliver care if we had, I definitely will speak personally on that. I wouldn't be the clinician and the person I am today in my medical professional role if it wasn't for patients and families who really imparted something into my life early on. It's the determination not to just spew answers out. We were talking about that. I heard people say, well, why don't radiologists do this? Or I also said, I can definitely tell when a physician has been a patient or had a family member who was touched by illness because their bedside and their approach to care usually is quite different. Caregivers, you are often the advocate, you're the note taker, you're the appointment setter, all these different hats that you wear. But every now and then I want you to take that hat off and just be Jayla. I want you to just be Betsy. I want you to just be, oh, did I see Eric? Did he leave? There he is. I want you to just be Eric. I want you to just be Mary Beth. I want you to just be you for just a small moment, because if you don't take the time to remember how cool this person is, how much this person loves other people, but also themselves, you will lose you in the process. And it becomes, on the tough days, it becomes even tougher. If you are literally working off of fumes, the tough days are harder. I know somebody talked about, what was the name for Scan Day? I heard of Scan Day. What was it? Scanxiety. on those days when you're trying to either yourself, I don't know if you stay out of the portal or jump right into it. I heard both sides of it. Oh, I dread going in there. And I heard, I heard other people like refresh, because you're trying to get that information because gosh, what else is going to come with this newfound information? Is it going to be good? Is it going to be bad? And always preparing for the what if is, again, do you really ever get a chance to let your mind release and allow your body? We are mind, body, and spirit. And if we thought that we were only we talked about some of the existential and do we need the chaplain and and it's not always a morbid conversation. We've got to kind of shake that stigma a bit too. Sometimes it's just us taking a check in on this inner person. How am I doing? And it's not sometimes until you sit down and ask that question that you really realize, you know what, I'm not okay today. I don't think anybody's asked me how I'm doing. I know when we get on the caregiver group sometimes, I'll say, all right, guys, how's everybody doing? Oh, well, this appointment and this happened and then that happened. And that's good to hear because it gives us an idea of where you are. But then I'll say, now how are you? And sometimes you have to remember to stop and ask yourself, how am I today? That's also why journaling is so helpful and a good use of time, because there's some things that you may write that you may not say out in the open because, oh, gosh, if I actually acknowledge that I'm scared, is that okay? Especially when I'm supposed to be your strength and I'm supposed to be, yeah, we got this and it's gonna be fine. But what if somewhere now I'm worried that maybe it may not be? And sometimes it's okay to have that conversation because it's important that you, one, are honest with what you're afraid of, but then two, it usually gets you open to talking about, so then what next? What else do I need to know about this fear? Because sometimes fear is just fear of the unknown, the lack of knowledge and information. I've loved watching some of you kind of clump together during the breaks and things and see who's talking to who and how you all are sharing, and I see nothing but smiles. I see lots of encouragement, and gosh, I think every time you look around the room, there's a hug happening somewhere. And the beauty in that is this, as a clinician, I can tell you and give you all the bullets of what to do and what not to do and think of this and then do that and eat this food and don't eat that food and yes, try keto, but don't. We can all go down those lists of things that we can give you from our clinical textbook experience, because we went to school for a little while to learn this stuff. You got dropped into the Cliff Note, the accelerated course. And so with that, you do, though, become your own experts to some degree, and you are very much a part of the medical team. Don't ever forget that. When you are an advocate and or a patient family, it's okay to say, I don't understand and I don't know. A lot of the words that you will hear us refer to when we're talking about all these, what are all these cytokines and things that we are drawing from the blood, and the bloodstream is a big highway. There's a lot of chemotactic, and that sounds big and fancy, but these are chemical taxis that are communicating. I'd say it that way. Chemotactic is a fancy word, but if I say it's a taxi carrying chemicals around the bloodstream that makes the brain and body respond, then it goes, oh, okay, I guess that makes a little more sense. Driving all through these highways, and what is it picking up along the way? What is it letting go of? And so you patients and families and caregivers, you become experts on some of this stuff over time. In the beginning, it can definitely feel daunting or like, gosh, it's so super overwhelming. But know that I love that picture. But over time, know that this journey is one that, does it become easier? Yeah, I think it does. Does it become less scary? Not all the time. But definitely building your network of friends, fellow cancer patients, warriors, survivors is important. But more than anything, too, again, not just for your clinicians and the providers, but also to meet people who are starting the journey, going through the same journey, or on the other side of it. I love last night when they were asking who has been, they said Ned, and today I think we're beating Ned up today, so we're going, he got a throat punch. No, right. What's funny is that a few people, we've talked about Ned a few times today, so I love that part of that analogy. While we like to see that there is no evidence, we never want that false sense of, oh, now I'm over this. Cancer is a scary thing. Kidney cancer, we want to give it the throat punch because it is such a sneaky cancer. but highly treatable, really good success rates, as you've heard from those here. Did we hear everybody being in NED? No, but what you're hearing is, I was given a 2-month prognosis and it was 5 years ago. We've heard the stories about the medical advancements, and we're worried about the research and what's going to happen with funding and along the way. But our committee, our foundation, as well as a lot of our other partners, we're looking to keep the charge going. And so your presence here today is a reflection of all the work that we are doing behind the scenes. It's what our pharma companies are doing to help support us in the effort. This is for you today, but for somebody tomorrow, and the next day, and the next day. So caregivers, patients, keep on the fight, keep doing what you're doing, but caregivers, don't get weary in well-doing. You are also then, at this moment, I'm paying homage to our caregivers in the room, because you do keep this charge going. You are the backbone of a lot of what we and your loved one, what we depend on. Because how often is it that we're in these deep conversations? I heard great questions and things today, but this is exactly why we do what we do. It's exactly why we're here. It's so that you have the information and the knowledge that you need to ask the next question, to make the next decision, to wake up one more day with a positive outlook to say, I don't know what today is going to bring. I don't know. I hope we're past the tsunami, but I want to be able to make it to that other side. I talked about Florence Chadwick. Several times she tried to do that swim. That last time before she was successful, when she got in the boat and they said, you were a mile away. And I think of, again, going back to Kathy and Tom, when that doctor said, go talk to hospice and palliative. Now, granted, conversations are one thing. Giving up and walking away, not so much, right? You get the information. You get the information. You talk about what your options are. You go along. Everything is about information and then checking in. How are we feeling with this? What is the next step for that? And I promise you, caregivers, not only will you continue to forge forward with your loved one, but then you've got to step away and take that time to say, whew, okay, now how do I feel today? Don't let the burden of the care or the guilt of being able to step away for yet a moment keep you from continuing to move forward in your love for your loved one, but also the fight. It can get long, but that's the blessing of it, right? Because once you have this diagnosis, the goal is not to shorten it or get out of it. Not right away anyway. We know this is a journey, and if you tell yourself, I hope this is quick and over tomorrow, you're going to set yourself up for failure and for disappointment. But instead, take every bit of the journey, take it in stride, get the information, but then also take care of you. Any questions? All right. Thank you.
Thank you again, Jayla, for a wonderful message. And I always feel like every time I hear her speak, I learn something new. So thank you again for all that you do for the JNF community. I'd like to present our last speaker, Dr. Zhao from Virginia Oncology Associates. He is a medical oncologist and hematologist, and he's going to be giving updates on rare kidney cancers.
Thank you for the invitation. It's truly an honor to know such a wonderful group of people from all over the state. I didn't know you guys are from all over, so that I thought it was a local event. But it's great to, I feel really honored to speak on a national meeting. Just for me, I'm a community oncologist with a special interest in GU cancer. Just briefly for Virginia Oncology Associates, we have more than 50 physician oncologists, more than about 100 mid-level providers. So we're part of U.S. Oncology Network. We have 9 locations, so my office is in Williamsburg. So the overview of the rare kidney cancer, so I wanted to share the classification. I know many of you know kidney cancer really well, better than me at a personal level. We can learn together and recap some clinical studies and have an idea of the evolving landscape of this type of cancer, and also share some unique features of biology of some cancer subtype. And so it's super important to participate in a clinical trial to move the field forward. We know the majority of kidney cancer are clear cell renal cell carcinoma. Then for the non-clear cell type are considered as rare kidney cancers. There's another emerging category is hereditary renal cell carcinoma. So there's a overlap feature between the two categories. Because of rarity and there's a limited data, especially lack of the phase 3 data to guide therapy, and the majority, the studies follow the clear cell renal cell carcinoma. So this is a slide shared by my friend Dr. Tian Zhang, our RCC specialist at UT Southwestern. About 25% of kidney cancer are non-clear cell type. The most common one is a papillary RCC, followed by chromophobe, then followed by collecting duct and translocation RCC and medullary RCC. Oncocytoma is mostly benign. There's also another kind of a small category called RCC with sarcomatoid features. It can happen across all histology subtype. This is a summary from NCCN guideline about the hereditary RCC. You can see some overlapping histology. Not only clear cell, but also papillary, chromophobe. So each non-clear cell RCC subtype has a unique feature. So the lumping all the subgroup together, so limit the signal of the efficacy, and even within the same histology, there's tumor heterogeneity, and then treatment based on biology generally work better than histology. These are the early studies basically following the step of clear cell type. At that point, these are the major 3 studies. At that point, there are only sunitinib and everolimus are available. So it did show some activity, confirm these agents are doable, but the activity is really very modest. The response rate in general is about 10+%. This Aspen study showed for chromophobe, the everolimus works better than sunitinib, while sunitinib works better than in other subtypes. Then the focus shift to papillary RCC because it's kind of just one of the most common subtype following clear cell RCC. The response rate is not great, but there's some activities. The bottom study shows the combination of bevacizumab and erlotinib has a significant response rate of 35% in papillary RCC, which led to a further study and showed even a better response. So in the French group, they found that the MET amplification and mutation overexpression is common in papillary RCC, especially for the type 1 subgroup, nearly 80%. As a result, the study was designed to target MET pathway. This was led at Dana-Farber called SAVOR trial, compared savolitinib and sunitinib. The top one is the MET inhibitor. The study did not close the enrollment because sunitinib arm had a kind of better response rate. But it did give us some signal that the targeting MET pathway may lead to a better outcome. So this led to another study with 4 arms comparing sunitinib, cabozantinib, crizotinib, and savolitinib. The bottom 2 arms closed early due to futility. For the comparison of cabo versus sunitinib, so the cabo stands out and provide a better progression-free survival. However, the long-term follow-up at 5 years did not show overall survival benefit. Then for immunotherapy start to take off, then it was also tested in papillary RCC. It does show modest activity. So that led to the combination of the 2 agents, tyrosine kinase inhibitor and immunotherapy. This is the Keynote B61 that used a single arm cohort study, a large cohort, using lenvatinib and pembrolizumab. It did include multiple non-clear cell RCCs subtype, include papillary, which showed initially a very impressive response rate, about 50%. The long-term follow-up showed about 43%. You can see also chromophobe was included in the study. This is a long-term follow-up with showing a fairly impressive survival. There's ongoing phase 3 studies we call Zemp study, which has accrued. We are waiting for the readout. This is basically the exciting arm is that savolitinib plus durvalumab. Switching gear to chromophobe, so the unique biology of chromophobe is it depends on the cysteine transport pathway. Inhibition of this pathway may have the potential to lead to suppression of this type of tumor. Another pathway is the KIT overexpression. So that's make conjugate antibody drug conjugates being a possibility in this subtype of tumor. Chromophobe in general is more indolent, so the potential to metastasize about 5 to 7%. So that most of the patients are killed by surgery. You found early. For metastatic chromophobe RCC, the standard of care at this moment would be either Lenvima plus pembro-based therapy based on the Keynote B61 or versus everolimus. There's also some patients treated with cabo-based treatment. There are 3 ongoing studies with some readouts showing the activity in chromophobe. But in general, chromophobe has a lower response rate than papillary RCC or clear cell RCC. For translocation RCC, it has a unique feature of TFE3, TFEV fusion. So it's an aggressive tumor, more common in female, younger patients. The diagnosis requires molecular confirmation. The response to TKI-IO combination is impressive in a 50% ballpark, either can be treated with Pembro versus Cabo-Nivo. There's an ongoing study at Dana-Farber, showing mitochondrial metabolism as a potential target. So the clinical trial being designed for this type of tumor. For renal medullary carcinoma, it is an aggressive type of cancer associated with sickle cell trait. In general, it doesn't respond to TKI, but chemotherapy may have initially a good chance of response, but the response doesn't last very long. There's also early study, anecdotal observation of response to immunotherapy. So as a result, there are ongoing studies either using Cabo plus immunotherapy or using some chemotherapy combination. So we know for clear cell RCC, the combination, IO combination work very well for a subgroup of patients. So that's also been tested in a large phase 2 study. This was reported at ESMO in 2024. So it shows a higher response rate with the combination ipi-nivo across the cancer subtype. About 32% across the subtype, and for papillary RCC about 30%. For chrome-4 was about 26%. So this survival at the 12 month mark is about 87%. But compared to Keynote B61, so we have 2 studies. So the showing the activities. Then how do we select frontline therapy? So I think both are reasonable. However, based on the side effect profile, the combination of ipi-nivo probably is not favored, unless the tumor there's a sarcomatoid tumor type subtype, or maybe PD-L1 positive tumor can be considered. So this is just for sarcomatoid featured RCC. It showed a better response to immunotherapy, especially combined IO. So ipi-nivo become the favored regimen. Just a summary and take-home message for this non-clear cell RCC. For papillary RCC, Pembro is now fairly standard frontline treatment. Cabo-based treatment is ongoing. For chrome-4, again, Pembro is a reasonable option. It may work better if PD-L1 is positive. Everolimus-based therapy is also a reasonable option. And for people with high tumor burden, symptomatic disease, there are also everolimus combination with bevacizumab. For translocation RCC, again, Pembro versus Cabo-Nivo are both good, reasonable options. For renal medullary cancer, it's an aggressive disease. Generally use chemotherapy and consider either radiation or clinical trial. With the RCCs with sarcomatoid features are preferred to be treated with the IO-IO combination. Then I wanted to also touch upon 2 studies on the hereditary renal cell RCC. So for one is VHL, the other one is hereditary myomatous renal cell RCC. So one is a clear cell, however, it has a unique biology. So the VHL involves inactivation of VHL pathway. That's lead to the upregulation of HIF2 alpha molecule that lead to the activation of VEGF pathway. So targeting this pathway by this medication called belzutifan lead to an impressive response and across the three subtype of tumor associated with this syndrome, and the duration can be long-lasting. And as a result, the treatment can actually save many patients from surgery. For HL-RCC, it's associated with fumarate hydratase loss. As a result, there's an upregulation of VEGF pathway and as well as the EGFR pathway. The combination of these two agents led to a very impressive response rate around 70%. This result was published in New England Journal of Medicine just 2 months ago. You can see the study actually included two subpopulations. One is there are 43 hereditary related RCC. The response rate was 72%, PFS was 21 months. For 40 patients with a sporadic papillary RCC, the response rate is much lower, although still very impressive at 35%. The median progression-free survival is also shorter at 8.9 months. So this is the example to show, even within the same histology, the biology actually dictates the response. Future direction, I think we are start to see the tunnel, the light at the end of the tunnel. So the hope of breakthroughs, especially with the genomics studies and the better categorization of the pathology, the artificial intelligence. And so we anticipate some breakthroughs in the next few years. Of course, clinical trial participation is very important. All right, thank you for your attention.
Just to put in context for people, if you look at the, as Dr. Zhao mentioned, the response rates for systemic therapies before now in these sort of subtypes was, much lower, 5 to 10%. So, the 35% response rates we're seeing with these agents now is really a significant improvement from what we saw previously. So I think, a lot of these trials, we're kind of on the cusp now of, I think, a revolution in the non-clear cell space where we're going to have a lot better therapies for patients with the non-clear subtypes and a lot better treatments going forward. So I think it's a nice sort of highlighting how those changes have really come about.
All right, thank you.
I promised y'all I was going to get you out of here on time. Thank you again. And I'm not breaking HIPAA here by saying this. So one of Dr. Zhao's slides, I've seen it, variations of it several times over the years, but it always gets me a little bit whenever I see it because I'm on there. You guys saw some of my medical data. I was in the PAPMET trial, and I was one of the 2 people that kept going. And so what I wish for all of you today is that you all have your own moment of that, because whenever I was diagnosed, I was given less than a year prognosis, and that was 9, almost 10 years ago now. So, thank you. And I wouldn't be here if it weren't for medical research. So again, to our earlier points, Judy Nicholson Foundation would appreciate you helping us out with our advocacy days coming up with Kidney Can. Again, I think that's where we are leading towards the future. So again, big thanks to the Judy Nicholson Foundation for providing this symposium. I hope that you all have some great takeaways from today. And also to our speakers, so Dr. O'Malley, Mark Manning, Dr. Viscuse, Dr. Logan Zemp, Lori Bumbaco, Kathy Russell, Jayla Barnes, and Dr. Zhao. We appreciate you and your time and sharing your knowledge and stories with us. I'd also like to thank my fellow board members with the Judy Nicholson Foundation and our sponsors, Merck, Aveo Oncology, Bristol Myers Squibb, and Alexis. And again, we invite you to please don't let this be the last time we see you. One, we want to see you in Vegas. I used to live there, so I'll make sure it's a good time, I promise you. And also, just please join us in being a champion for JNF. There's a lot of wonderful organizations within the kidney cancer community, but we really take it to heart to make sure we are providing quality content and support for patients and caregivers specifically. And so whether you're called to lead by that by a small donation, we appreciate that. Every dollar truly does count. We move a lot of things around and try to make sure we're moving all the money to where it's going towards patients and caregiver support. And follow us online. Again, if you aren't already, please do so. We're on Facebook, Instagram, and LinkedIn, and invite you also to share any of your wonderful stories and takeaways from today and yesterday online as well. So I will close us out with my dear friend, Pastor Walter Johnson, to give us a closing prayer. He is also our government affairs liaison for JNF. And thank you again for your time and attention today, and we hope to see you again soon.
Let me also give a special thanks to Linda, Tracy. The work before the symposium can be awesome. They did a great job. One of the things I've done before I give this quick prayer, I was early diagnosis. I'm cancer-free, 15 years. But after that, being a pastor, I decided to become a hospital chaplain. So for about 5 years, I was a chaplain over at Baptist Hospital. I got to meet some of the nicest people in the world. But being a kidney cancer advocate, I have met the nicest people in this world. I'm serious. And so all my colleagues on the foundation, and to all of you, our prayer is every day gets better. Let's stand together. Thank you, Lord, for this fantastic symposium. We arrived safely, and now as we get ready to depart, our prayer is that you will watch over us. We take nothing for granted. We know that every day is precious. Thank you for the testimonies we've heard. Thank you for all of these fantastic medical professionals that have displayed their knowledge and insights to us. We leave here a little better, just a teeny bit better than when we arrived, because we have more hope now. We know that we're not fighting by ourselves. We thank you that for the last 24 hours, we were able to lean on each other just a little bit and share our stories. But as long as we have our minds intact, we will never forget each other. So bless those from so many different parts of this country. As they return home, give all of us safe passage. And if it be your will, let us get together again soon. In the name of our Lord we pray. Amen.